Okay, so hello and welcome to our virtual discovery day focused on mental health and type 1 diabetes. There are some really interesting results there in the poll questions. There's many different issues and it's lovely to see you all, and it's great to have such a diverse group with us today. My name is Hilary. As well as the host of today, I'm also the very proud director of Policy, Communications and Community Engagement here at JDRF UK. We hope you all have an opportunity to take part in the quick poll at the opening of the event. Some really interesting results there in terms of how the type 1 diabetes in your life is managed and your relationship to the condition. Today, we're shedding a further light on an important conversation for those with type 1 diabetes as we discuss the impact of type 1 on mental health. In this event, we're going to bring you insight from some of the healthcare professional experts, as well as some of the brilliant experiences from our type 1 community, which we hope will add to your understanding and your tools to help you look after your mental health. We've got an exciting lineup for this morning and a big thank you for everyone to joining us. But first, to give you some insight on JDRF firstly, for those who might be new to JDRF, we are the leading global organisation funding type 1 diabetes research. Our strength lies in our exclusive focus and singular influence on the worldwide effort to end T1D. Our vision is a world without type 1 diabetes. We work with the UK government's two major funding bodies, the Medical Research Council and the National Institute of Health Research, to make type 1 diabetes research. And we work with government departments like the Department of Health, for example, to make them understand the impact of type 1 diabetes on the UK and the excellence of our research mission that we can provide through our global research. So our mission is to improve lives today and tomorrow by accelerating life-changing breakthroughs to cure, prevent and treat type 1 diabetes and its complications. The more excellent type 1 diabetes we get funded, the quicker we can drive developments to cure, treat and prevent type 1 diabetes. Also, we do partnerships in the UK. So, for example, we have something called Connect Immune Research, which we advocate for the development of a connected research community focused on autoimmune conditions across the UK to generate advances in the knowledge and treatments for people living with autoimmune conditions, particularly type 1 diabetes. We want to say a huge thank you to our sponsors for this morning's event, who help us make events like this happen. So thank you to Abbott, Air Liquide, Dexcom, Insulet and Medtronic. Just a little bit of housekeeping for today. So in terms of improving your experience today, our event is hosted via Zoom. To prevent technical difficulties, we recommend you keeping other internet use to a minimum. I'm going to say straight off, I know that's easier said than done. I have a young family and there's plenty of streaming going on in the background. But if you can, I do recommend keeping other internet use to a minimum. Do protect your identity. If you wish, your camera and microphone can be automatically turned off so we can't see or hear you. Get to know each other. I and your chat host today, David and Chris, are here. Feel free to use the chat feature to talk amongst yourselves, share experiences of managing type 1 diabetes, as well as your feelings and experience around all things around this subject area. And if you've got a question for a speaker or a tech company or an individual, go to the Q&A section and put the person's name and company in brackets and ask away. Some topics or conversation we know may be triggering for some. So of course we understand if you need to click away. So here is a glance at our agenda for today. And as you'll see, it's a packed agenda with some amazing guest speakers involved in our sessions. Just a couple of things to note are that our comfort breaks will fall at 10:50 and 11:25 to help you grab those refreshments. And we aim to finish about 1 p.m. So that's what we're going to be doing through this morning. And now I'm absolutely thrilled to bring out our first speaker. So it's my pleasure to introduce Natalie Zaremba. Natalie is a researcher and trial manager at King's College London, working on the psychology within the area of diabetes. Her research focuses on the lived experience of people with diabetes. She also lives with type 1 herself. And she's going to kick us off today talking about the impact of type 1 of diabetes on mental health. But that's enough from me, and I'm going to hand over to Natalie now. Natalie, welcome.
Hi, thank you so much for that introduction and for having me here today. I'm really happy to be able to talk about this with you this morning. So I'm going to be talking about a bit of an introduction into mental health and diabetes, and also share some of the research that's happening in this area. Next slide, please. Sorry, I've had some technical difficulties, so I have to present through JDRF, and they're very kindly supporting me. And yeah. So I thought I'd give a quick introduction to myself and a bit of my background. So I was diagnosed with type 1 diabetes on January 1st, 2005, just over 18 years ago. And I grew up in Canada, navigating the Canadian healthcare system. And at my diagnosis, I always kind of knew that diabetes impacted my life in a lot of kind of physical and practical ways. I had to check my glucose and do my insulin. But at my diagnosis and growing up, no one really talked about the emotional or mental side of diabetes. And so I just didn't really know that it existed. I didn't realize that there was an impact. And I was very lucky to have a lot of support from my parents, who tried their best to make my life with diabetes as easy for me as possible and to make sure I never felt too different from others. I had a pretty good pediatric diabetes team, and my friends were really understanding and wanted to learn about diabetes and things that I needed. So overall, I had a lot of support, and I was, aware that diabetes impacted my physical health and my daily life. But I didn't realize how it impacted me emotionally until I was an adult and I was in university. And I was working with Diabetes Canada and their summer camp programs, working with kids and teens with type 1 diabetes, and also running my university's Diabetes Society. And there's a picture of us in 2012 at World Diabetes Day. And it was when I began talking with other people and hearing their experiences in their own words about the things that they were struggling with diabetes, and learning about kind of the mental burden. And I began to realize that actually all of these things impacted me too in different ways. And I learned actually diabetes is really hard. And so when I finished university, I decided to come to the UK and do a master's degree in health psychology. And I wanted to know more about how your health and living with a chronic condition like diabetes can impact your mental health, and how we can lighten that burden for people with diabetes and make diabetes a little bit easier. And so since I came to the UK, I've been working in diabetes and psychology research. Next slide, please. So how does diabetes impact your mental health? Well, the research tells us that both depression and anxiety are more common in people with type 1 diabetes than in those without. We know that 30% of kids and adolescents have depressive symptoms and 32% have anxiety symptoms. And in adults, depression is 3 times more common in people with type 1, and anxiety is 5 times more common in people with type 1 than don't have diabetes. In terms of eating disorders, which I'll talk a bit more in depth about later today, they are roughly twice as common in people with type 1 diabetes than in those without. And these are pretty substantial numbers. So why does this happen? Next slide, please. A huge component of this is diabetes distress. And this might be a new term for some people. So just to kind of clarify, diabetes distress is defined as a negative emotional experience resulting from the challenge of living with the demands of diabetes. And it's different from depression and anxiety and general emotional well-being. So diabetes distress is a really specific and measurable thing that's different to all of these other mental health things. And not everyone who experiences diabetes distress will have depression or anxiety, but they can often be related and impact one another. And this, in a way, makes a lot of sense. Diabetes impacts every area of our lives in some way. It's constant, there's no break from it, and it's demanding. So experiencing all of these challenges makes sense that it would impact us emotionally. And there are a lot of reasons people may feel diabetes distress, and these often include feeling powerless or feeling pressure to be perfect in your diabetes, that you'll never be good enough and achieve the things that your healthcare professionals or things that you feel that you have to in your diabetes. There's a lot of stigma and feeling that people treat you differently because of diabetes. Maybe your doctors don't understand or know enough about diabetes, or your friends and family don't understand and make diabetes a bigger deal than you feel it is, or minimize what you go through. There's fear of hypoglycemia and complications, the burden of diabetes management and all the daily tasks and decisions that you have to make, and distress about food choices and eating. So you can see that diabetes distress is really complex, and it's really important for healthcare professionals and diabetes teams to keep an eye out for people who may be struggling with different areas of diabetes, to listen to our concerns and to provide support the best that they can. Next slide, please. And so before we get into some research, I also want to address stigma, which is something that so many people experience in their daily lives with diabetes. So stigma can look like a lot of things. It often looks like blame. People are blamed for developing diabetes or feel that it's their fault for not managing it well enough. There's negative social judgments, and people are judged by others for having diabetes. People may feel excluded from certain groups or activities or events that might not be accessible or allow accommodations for diabetes. And some people experience even outright discrimination. And stigma can come from a lot of different sources, and we see it a lot in the media, both on social media and also the news, TV shows, diabetes jokes. And it comes from healthcare professionals, friends, and families and colleagues as well. And there are very real consequences of stigma. It leads to diabetes distress, and it can impact people's relationships, their social identity, how they see themselves and interact with others, their emotional well-being, and rates of anxiety and depression, as we've learned earlier, hiding their diabetes from others, which can influence diabetes management and make it more difficult, and even perpetuate other forms of stigma by trying to distance type 1 diabetes from type 2 diabetes. Some early data from the Diatribe Foundation in the US that was presented at the ATTD conference in February shows that stigma impacts people's diabetes management choices and their willingness to use diabetes devices. So in their study, 1 in 5 people who didn't use a CGM or insulin pump reported that stigma impacted their decisions to use or not to use these diabetes devices. And of course, this study was done in the US, and I think the biggest factor for them was actually financial accessibility to diabetes devices, which, of course, financial stress will also have a negative impact on your mental health. And they found that a lot of people who use diabetes devices reported discrimination, people making hurtful jokes or comments. They received unwanted attention, and sometimes they were asked to remove their diabetes device for non-medical reasons. And so we can see that stigma is really quite serious and have real measurable consequences. Next slide. Thank you. So I'm going to talk a little bit about research now, and there are still many more ways that diabetes can impact mental health and different ways that it shows up in our daily lives. But I think there's a lot of cool research happening, and we should kind of explore that. So why do we do research? Why do we need it? We often think of research in diabetes being about treatments and new technologies and medications and clinical trials, very physical health related things. And all that's very important because it helps regulators to make decisions about new kinds of treatments, how it will benefit people, how to prescribe new medications and set guidelines. And this is also the case for research in mental health, but in a condition that's usually thought of as just a physical condition, mental health research can often lag behind a little bit. And so we need research to actually document the fact that there are things missing in mental health care and diabetes. And we need research to document in a kind of systematic and scientific way the problems that we're experiencing, because until that evidence exists in kind of a scientific format and in a measurable way, doctors and regulators can't put anything in place to help us. And something that's becoming increasingly important and more common is the involvement of people with diabetes within the research process. So this can be through things like PPI groups, patient and public involvement, where people with diabetes can be involved in the research design process and help guide the direction of research and provide feedback in different ways and formats. And also through lived experience and co-design research, and I'll talk a little bit about that in a minute, where people with diabetes are seen as equals to the healthcare professionals in the research design process, and their experience can help to design a service or an intervention together. Next slide, please. So one example that we'll hear a little bit more about this afternoon is the STEADY project, which is for safe management of people with type 1 diabetes and eating disorders study. And in this project that I work on at King's, we've developed a new intervention for type 1 diabetes and disordered eating together with people with lived experience of this condition, and it's currently being tested in a randomized control trial. But we'll hear more about the details of that later. Next slide, please. Another group of researchers at King's College London recently did a project with young people with type 1 diabetes who were transitioning from primary school to secondary school. And they used experience-based co-design with young people who were between 11 and 13 years old and designed an animation that addressed these things that were important to these students during their transition. I won't play it, but if you'd like to see it, it's available on YouTube. You can follow the QR code and have a look. There are a couple of screenshots here. You may have already seen it online. And it's a great animation, and there's more work to be done to help students at this age make their transition to secondary school a little bit more easily. Next slide, please. I'm also part of the team at King's College London working on the hypometric study, which is looking at a lot of things in relation to hypoglycemia, but one of the main outcomes is to see how hypoglycemia impacts people with diabetes and our daily functioning. So our quality of life and also physical things that impact that as well. So people with both type 1 and type 2 diabetes using insulin took part in the study for 10 weeks, and they wore a Freestyle Libre that was blinded so that they couldn't see their glucose during the study, so that they couldn't change anything based on the study only. If they had their own sensors, then they were free to use those still. But they took part for 10 weeks and completed questions on an app 3 times a day about how they were feeling generally and also if they had hypos that day. And we looked at hypos that they were aware of and had symptoms for, or that they saw on their own sensor, and also hypos that they didn't know that they were having. And we looked to see how they impacted sleep quality, physical functioning, things like energy levels, emotional impact like mood, cognitive functioning like memory, fear of hypoglycemia, and also high glucose, and how hypos impacted social functioning and things like work and productivity in their daily lives. We're in the process of analyzing and publishing our results, but it's a really important study to show how much hypoglycemia impacts every aspect of people's well-being in diabetes.
Thank you, Natalie. Just to say another 3 minutes, if that's okay.
Sure, yes. Other researchers in the wider HypoResolve project did interviews with people with type 1 to ask about support they would like or support that they felt was missing. And they found a lot of different things, from even just understanding that recovery from a hypo takes time, And sometimes living with diabetes and deviating from your routine is a bit of a risk because it can cause you to become hypo, and that's quite scary. Some people mentioned how much technology like CGMs can make a difference and improve their diabetes management, and even things like basic diabetes education on how to adjust insulin levels. All of these things are missing, or at least lacking, in some parts of the UK and around the world, and so it's really important that research highlights this. Next slide, please. There's also a lot of research happening now about new technologies and how that impacts well-being. There are researchers at the University of Northumbria who are looking at how using Freestyle Libre impacts both diabetes management outcomes, but also psychological well-being and quality of life. And there's also a lot of research happening around the world about closed-loop systems, how they benefit people with diabetes, where the challenges are, and how healthcare professionals can support them and make using both commercial closed-loop systems and DIY closed-loop systems easier. And these are just a few of the studies that have come out, but it's a really huge field and there's a lot happening. And at the ATTD conference in Berlin last month, which is a technology conference, there was a lot of great sessions that focused on lived experiences and what matters to people with diabetes, which is really encouraging to see. Next slide, please. Last November, the NHS, in partnership with JDRF and Diabetes UK, published this document on the 6 principles of peer support for people with type 1 diabetes. And I think this is an incredible step to have concrete guidance on establishing peer support for people and kind of combat that isolation that many people with diabetes feel. So peer support is drawing on the shared experiences to help each other with knowledge, information, and support. And people with type 1 diabetes were involved in making these principles along with researchers, clinicians, and policymakers, and it outlines how peer support should be established and run for people with diabetes to share their experiences, support one another, and again, feel less isolated. And I think that there's more work coming from this group, and I'm really looking forward to seeing what's next. Last slide, please. So to finish off, managing diabetes is really hard work, and I think everyone who lives with diabetes will know this and will probably struggle with the demands of diabetes at some point. Diabetes impacts our mental health in a lot of different ways, and I can only mention some of them today because it's such a huge topic and there's too much to cover in a short session like this. But we need more mental health support for people with type 1 diabetes, and the research backs this up. And I'm really happy to say that there is more and more research in mental health and diabetes coming, and the importance of it is more well known now. And I'm excited to see what the future brings for research and development in support. So thank you so much for your time today and for listening. And if there's time, I'm happy to answer any questions. And if not, then I'm happy to answer questions in the panel later on today. Thank you.
Thank you so much, Natalie. That's absolutely fantastic. And I think one of the things that I see is that, you know, over the course, for example, of JDRF's 40, 50-year history, there's always been the focus on biomedical treatments, and now actually that sense of the parity of mental health and physical health and the need for research for evidence-based interventions, and it's growing. And it's been very much driven by what people with type 1 are actually saying themselves, saying, I want to be able to live a life without anxiety, without burnout, without distress, and understanding that intersection between the physical nature of the condition and the mental health impact. And I'm so delighted to see the work that you're doing and that overview. I want to say to everyone, I know there's some issues around sound quality for some, not all, for some, and we're working to rectify that. Also, please do put your questions in the Q&A. And it's also not just about the people that are presenting who can then answer those Q&A. I know that we've got a question about, you know, I've got a son with type 1, we're just starting this journey, what advice can people give? And this is really meant to be an event where everyone can support each other with their own experience. So please do contribute in terms of that question and answer with your questions, but also your lived experience as a panelist. So I want to say thank you so much to Natalie. That was a superb insight into your research and also the overarching structure and momentum around research and mental health. So what I'm going to do now is I'm going to pass to Melissa Holloway, who many of you will know as an absolute expert and advocate in the T1D space. And she's going to talk about the challenges of managing data in diabetes. So Melissa, over to you. A huge and hearty welcome. Thank you.
I hope this recording will do the topic justice. The last time I spoke on a JDRF virtual event, I covered diabetes data and how and why people might share it. For this time, the team asked me to talk about the challenges of managing data for diabetes. I come to the topic with my personal experience of living with type 1 for almost 29 years. My anniversary is just a few weeks away. I've used an insulin pump for almost 27 years and CGM for over 16 years. In the last couple of years before I got CGM, I did 10 to 12 finger sticks a day. I've been a DIY hybrid closed loop user for almost 5 years. So I've dealt with plenty of diabetes data over the years. And once it became possible to download my diabetes devices at clinic, I gave up keeping written logs because I could not be bothered. Sometimes the patterns that have shown up in my data when I looked at the numbers on my own or with my healthcare team have really surprised me. Like when I tried a CGM for the first time in a clinical study in 2006 and worked out that I wasn't dealing with dawn phenomenon anymore. I was actually eating a very late, low glycemic index dinner, and the higher basal rate I used from 3 to 6 a.m. was acting like a bolus. Or when I was pregnant with my second child, and for about 10 days in the middle of the second trimester, my rate of digestion perfectly matched what my DIY looping system could handle, and I barely had to bolus at all. That was quite something. But more often than not, I log into my diabetes data management system or look at my weekly Dexcom Clarity email kind of like this. I know from day to day I'm doing the best I can under the circumstances, but the charts don't show the stories that explain the highest highs or the lowest lows. I have to be the keeper of these. Was that spike because I forgot to bolus? My fault. Or because my pump cannula got kinked? Not my fault. Or was that sharp drop due to a hypo because of a rage bolus? My bad. Or because I was way off on a carb estimate? I tried. Or was it just one of those things that happened because I have diabetes? Sometimes that's all there is to say. It's diabetes. Now to get into the structure of where this talk is going. It's going somewhere, I promise. First, I'll define what I mean by managing data for diabetes. Next, why it matters. After that, who is or should be involved, and when and where do we deal with it. Finally, I'll share some thoughts on how we can use our data. The image on this slide bothers me a bit because it uses the terms poor, fair, and excellent to describe diabetes control. I've used it because it really underscores how humans, healthcare professionals, and ourselves included, attach value judgments to data. So before we get on to talking about managing data for diabetes, let's get on the same page about diabetes data. Today, the focus is on personal diabetes data. In addition to the types of data I mentioned in my other talk, I've added a box for HbA1c here. I've grayed out the GP prescriptions, open prescribing, and NHS statistics boxes because I'm not focusing on those today. So now I've defined what I mean by diabetes data. What about the challenges of managing it? I'd like to start with this picture of an abacus. For many of us as children, the concept of numbers preceded the number symbols. There were colors and patterns, and we counted on our fingers too. We sang songs like 10 Little Monkeys Jumping on the Bed. Just as a disclaimer, I don't actually remember a lot about how I learned about numbers, but my daughter is 3, so this is my life now. The concepts of numbers became digits, and digits led us to fractions and percentages. The dashboard type image is some random shot, nothing to do with diabetes, but it could be about health or finance or retail stock, anything we can measure. And we still use colors to add meaning to the information. But somewhere along the line, numbers got the power to stir emotions in us. This image really struck me because I have definitely done this. Out of frustration, shock, discouragement, sadness, or feeling overwhelmed. Sometimes the feelings we get, move myself here, from numbers are not our own, they're other people's. As a stock image, this picture really struck me because we don't really see the face of the woman. Her expression could be serious or neutral, but the man, he's giving it a proper how much, like my husband did when we got a household bill the other day. And finally, this picture. We're probably looking at social media and seeing others who seem to be having a great time. It's simple to say I'm happy for people when they find something that works for them and want to celebrate. But the complex reality is that things are rarely as great as they look on Instagram. The other day, I saw a mom friend who'd been on a short trip to a sunny place where she has a holiday home. I commented that it looked from her pictures like she'd had a really nice break. Turns out she'd had quite a lot of shopping to do for the holiday place. She was quite stressed after the weather there turned very rainy. And as it's a rental, she's now a little concerned about whether the landlord might want to change the terms of their lease after she's just put time and money into making the place really nice for summer. That was not the answer I was expecting. I realized that last week, as I was getting over a bad cold and the weather here wasn't brilliant, I'd been ever so slightly jealous. I assumed she was having a good time because she put those pictures online. And I didn't actually ask her how her trip was. Which brings me to this picture. Whether the word should be failures or perhaps learning curves, I think this rings true. The honesty of one person admitting that it looks like other people have it better, and the reassurance this is probably not the case. So to go back to data, I have another picture to share. This is one of the best things I've seen online. The top part of the picture shows a pile of Lego, which can be sorted into colors and arranged, or even presented visually. But the bottom image of a house shows the power of having a story along with the data. Your mind would never be able to go from the pile of bricks at the top to the house at the bottom. But once you see the house, it has meaning. The potential was there all along. Now I have a few quotes about data. The first one is the definition of anecdata. This is a sort of a new word, a portmanteau, based on anecdote. I hope we've all experienced the power of a story to communicate about the human condition or shed light on a unique experience. But there's a line between story and data, and sometimes it gets blurry. There is some controversy about whether the plural of anecdote is data or not. Personally, I think it can be, but one person's experience is not likely to be all that broad. Next, there are three kinds of lies: lies, damned lies, and statistics. This quote is often attributed to Mark Twain, but who really knows? The point is that numbers do not always tell the whole truth about a situation. And finally, one that I love to throw out when someone is doing research to support an idea they want to promote. Many people use statistics like a drunk man uses lampposts for support rather than illumination. There are times when we can totally find a fact to fit a story we wish to be true, even when there are other facts that might tell a different story. The term confirmation bias is related to this idea. If your point of view is that you have trouble with something, you may find it easier to think of times when that thing did not go well. If someone points out that this isn't always the case, you may explain it by saying that was a rare exception. But if you're actually to analyze the data and consider what happens when that thing seems to work versus when it doesn't, you might find that your impression isn't as accurate as you thought. So what does all this have to do with diabetes? A lot, in my opinion. The top image here is called The Many Faces of a 7% A1C. What I like about it is it emphasizes how time in range tells much more of a story than A1C. In terms of confirmation bias, a healthcare professional or a person with diabetes who sees the 7 may think someone has quote unquote good control. But when you look at the time in range and then the example of how a sample day might look for someone with that time in range breakdown next to it, the story is quite different. The graph on the left shows an equal amount of time in range and time above range, with a dangerous amount of time below range. These kinds of highs and lows are no fun, and they probably have a significant impact on someone's quality of life. In terms of day-to-day life, maybe they feel really frustrated. In terms of treatment, maybe they need a different correction factor and some support around how they bolus for meals. But if all we saw was the 7% A1C, they'd probably be told that they're doing fine. This is as good as it gets. Now for the middle, this split on time in range is close to the goals stated in the international consensus. According to the international consensus on time in range, most people with diabetes should aim to be below range less than 4% of the time and in range at least 70% of the time. In this pie chart, this person's not too far off that. What we get here is someone who's spending most of their time in the target range, not a lot of time hypo, and maybe they're hanging out above target a little more than would be ideal. But maybe they're feeling quite stressed about the time that they're above target and might need some reassurance that this is not necessarily a problem. Or maybe they could use a bit of a refresher on how to handle certain meals to shift just a bit of that time above range into range without increasing the risk of hypos. But again, if all we saw was a 7% A1C, they'd probably be told that this is fine. They're doing well. This is as good as it gets. Finally, the 100% time in range graph over here. Not a whole lot to see here, folks, except that this person has such gentle fluctuations. Maybe they could do with a bit more of whatever diabetes medication they're on in order to aim for an A1C a little closer to 6.5%. But that would depend on a few factors. For example, if they're quite elderly or dealing with multiple different medical conditions, this might be just fine. And again, if all we saw was the 7% A1C, they'd probably be told that this is as good as it gets, that they're doing fine, and there wouldn't even be a discussion about whether this was actually ideal for them in their situation. The next picture is a clearer illustration of the story that an AGP, or ambulatory glucose profile, can tell. An AGP is a way of visualizing the average patterns in someone's glucose levels over a period of time. In this example, it looks like overnights are very likely to be in target, but then once they eat lunch, things really go high, and they go high again after dinner. And some days are higher than others, as the gray dashed line shows, for sure. And these show the highest and the lowest recorded in the time period. A look at this AGP could lead a DSN and a dietitian to talk through ways of handling school dinners and how to dose for meals at home, because the data show that the roller coaster from school is continuing at home. And finally, this just tickles me. If you look at the actual data, this person started their day with a glucose level around 9, and they had a real time of it till they finished the day at around 9. This is not a day I would like to have, but they drew cats on it, because don't those peaks just look like ears? Which brings me to this other thing I love from the internet, the idea that if someone from the 1950s suddenly saw what life is like today, the most difficult thing to explain to them would be a mobile phone. I possess a device in my pocket that is capable of accessing the entirety of information known to man. I use it to look at pictures of cats and get in arguments with strangers. We have a choice about how we engage with the diabetes online community and whether we start to argue about the data or whether we use it for, upbuilding and learning what works for each other and ourselves. And on a more reflective note, the percentage of our worst days we've made it through stands at 100%. Whatever your time in range, whatever your A1C, whatever you measure or count, you have made it through all your worst days, and that is a good statistic. So how about who should be involved? This is a short slide. Basically you, your diabetes team, and whoever you choose. It's your data. If you don't want to share it with other people, don't. If you do, do. If things have changed for you or in your relationship with someone who sees your data, say something. There's an emerging phenomenon of people having to remove their parents and ex-partners as CGM followers. Psychologists are studying this because it's rather a big deal, and it's something that wasn't a thing until recently. And if it's something that affects you, it's okay to have feelings about it. Because ultimately, the diabetes data belongs first to the person with diabetes. So another wise word slide coming up. This one's kind of overarching. Whether it's your own journey with diabetes management or how you handle your data, don't compare your beginning with someone else's middle. There are lots of people with stories of what changed their life for the better. Doesn't mean anyone who doesn't do that or have that is not going in the right direction. Another phrase I think goes along with this one is comparisonitis, comparing one's accomplishments to another's to determine relative importance. We all have the same number of minutes in a day, but we have different needs and priorities to deal with. So take it easy, take a deep breath, and keep going. So that said, when and where do we deal with the challenges of managing diabetes data? I don't have a real answer here except to say it's got to be on our terms. But doing it ourselves doesn't have to mean doing it alone. The main thing is it doesn't have to feel like a surprise when we go to clinic. It does seem like a lot of people don't dig into their own data before a diabetes clinic visit. The nurses and healthcare assistants at my clinic are always taken aback a bit when I say I don't have a device for them to download because I already did it myself. I'm looking forward to the day when they say, we've already got your data because the uploading is all automatic and we don't have to take any time to do it. But even when that happens, we get to see what it says and decide on what we want to talk about with the team. This also goes for how we share with loved ones. And I've added in here that the screenshots on social media you may choose to share could be on your terms. It's not a competition. And you can also develop collaborations. Some friends have reached out to me via Facebook Messenger and said, could we have a talk about my data? Could we do a screen share? And I like it when that happens. And sometimes I've reached out to my friends to ask if they'd help me take a look at a pattern. And it can really help to have someone's eyes on it. So for some parting thoughts, it's your data. Make the most of it. And who you share and how you share is up to you because it's yours. And that another quote I really like, comparison is the thief of joy. The only person I'm trying to be better than is the person I was yesterday, is something I feel balances this idea very well. I'm trying to be a better mom. I'm trying to be a better wife. I'm trying to be a better daughter. I'm trying to be a better collaborator with the people I work on projects with. I'm trying to manage my diabetes better too, but it's not the only thing I've got going on. And I'm sure that the same is true for everyone here. So we all deserve a big high five at the end of the day. And that's where I'd like to wind up. Even if it's just a dog high five, that's a good high five. And we all deserve one. And finally, thank you for your time and attention today. And if you'd like to drop me a line by email, here's how. Bye.
Thank you. And I hope that was really useful for everyone. Life with type 1 diabetes, especially with medical technology, has changed, and with that comes huge opportunities, but also huge challenges as well. So I hope that was a useful overview in managing data and navigating that in relation to mental health. And given the fact that so much has actually changed in terms of the use of devices and technology, I just want to give a couple of minutes to Abbott in terms of Flash to give a bit of insight into mental health, and then a couple of minutes to Air Liquid, and then we'll go into a comfort break in about 5 minutes time. So over to Frankie Proctor from Abbott.
Hello everyone, thank you all. So my name is Frankie and I work for Abbott Diabetes Care, and what I want to talk to you today is about Freestyle Libre 2 and Freestyle Libre 3. So I'm just going to share my screen and get up the presentation. So thank you to JDRF for having me this morning. So What we have at Abbott Diabetes Care for patients with diabetes is a portfolio of products. So we have flash glucose monitoring devices, which is Freestyle Libre 2. And what you get with Freestyle Libre 2 is a small sensor, roughly about the size of a £2 coin, that you wear on your arm for 14 days. It's simple, easy to use technology that doesn't require any fingerprint testing. You also get optional glucose alarms on the Freestyle Libre 2 system, which means that you can turn on alarms to alarm you if your glucose is either going too low or too high. And you also get comprehensive data which provides insight into enabling you to drive change in your diabetes management. With Freestyle Libre 2, because it's a flash glucose monitoring device, you do have to scan the sensor roughly about every 8 hours to have a continual 8-hour history graph. What we have now, so our newest product with Freestyle Libre 3 to Abbott is continuous glucose monitoring, and that is Freestyle Libre 3. And Freestyle Libre 3 is a real-time CGM device. So Freestyle Libre 3 is a very small sensor, so it's the smallest CGM sensor out there on the market. It's less than a £1 coin in terms of the size. Freestyle Libre 3 sensor is streaming data and alarms to aid complex disease management, and it's simple, easy to use, innovative technology. So no more fingerprint testing or no more scanning is required. The Freestyle Libre 3 sensor is a 14-day sensor, and you'll still get all the same benefits and features as you get as Libre 2, but on Libre 3 as well. Sorry, I've just set a timer so I know when to stop. So I'm going to stop sharing now, as I believe that's my time over. Thank you all for listening today.
Thank you. And I think what we're seeing with some of the technology is the improvements, which also just helps to reduce the burden of managing it. I'd like to now go over to Air Liquide, and apologies for my pronunciation.
Okay. It's easy. It throws a few people, Hilary. So
that's okay. I'm going to introduce you as Ms. Higgins, if that's okay.
Yeah, I'll go with that.
Over to you.
Thank you so much, and thanks for the invite today. It's really, really interesting to hear about mental health and diabetes. So really interesting topic. So today, I'm just going to do a brief overview on some of the key features and benefits of the Tandem t:slim. So I'll just have a few short slides. So the t:slim can be integrated with the Dexcom G6. So that's continuous glucose monitoring, and there's the option of 2 different technologies with that. So you can have the Basal IQ, which prevents lows, and the Control IQ, which is the hybrid closed loop technology. So the key features of the t:slim pump are the fact that it is a rechargeable battery. It has a color touch screen and built-in Bluetooth for future use. We have remote upgrades. So if you have a pump and the warranty is 4 years, we can send software updates via email to you, and you can update it like a bit like a smartphone, a bit like an iOS update. So you'll have the latest technology at your fingertips. It's watertight, and we have a patient-focused 24-hour support team, and they're based in the UK. The t:slim has a small footprint. It's small and sleek and easy to wear, and it has an innovative cartridge design, holds up to 300 units of insulin. So the Control IQ, just to do a wee short summary in the Control IQ, it's the advanced hybrid closed loop technology designed to help increase your time in range. It works with the Dexcom G6. And the icons display on the pump indicates whether your insulin is increasing, decreasing, or stopped. So you can see by a diamond on the front of the screen what exactly is happening. It may be worthwhile, anyone that's interested in the t:slim, if you want to download the T-Simulator, which basically acts like a pump. It's totally free of charge. You can get it on iOS or Android phones, and it's really good as an educational tool, or if you wanted to play around and just see what the pump looks like. And that's me. So thank you very much.
Thank you ever so much. And I know there's something in the chat also talking about the burden of technology, and I think some of our speakers as we go through the morning will also be able to pick up that. But I think that the technology is changing and it is aware of burden, and it is always looking to see how to reduce that. So we're at 10:52. We're 2 minutes over, which actually I think is pretty good. So we will come back in, we'll start at 2 minutes past 11 with a 2-minute overview from Dexcom, and then I'm going to be really pleased to introduce Rose Stewart, who really is one of the UK's leading experts in diabetes psychology. So I look forward, everyone, to seeing you in about 10 minutes time after a comfort break. Thank you. Welcome back, everyone. To give an overview, you might see that we've got over 100 people here today, so please do use the chat. I think we've had over 100 different questions and answers on the chat. This is your event. This is a way to connect with people. This is a way to ask your questions. So as well as the presentations, keep those chats going. Now, I'm delighted for the next couple of minutes to hand over to Caroline from Dexcom to be able to talk a little bit about Dexcom's devices, and then we'll move to Rose Stewart after that. Caroline, welcome.
Thank you. Great to be here, everyone. Really enjoying being part of this session today. So you've got myself and Kirsty on the chat if you have any questions at all. We're going to play a short video for you, but just to highlight that we have a fantastic community of people with diabetes also using Dexcom. They're called our Dexcom Warriors. If you'd like to be part of that community to continue to support each other, then you can sign up on our website. So if the team could please play the Dexcom video, that would be great. Thank you. Thank you, everyone. Kirsty and I will be around to answer any questions you may have.
Thank you. So do keep those questions going in the chat. And now I'd love to introduce you to Dr. Rose Stewart, who's one of the UK's leaders in diabetes and psychology. I'm working a lot with Rose right now. We're currently collaborating on a parliamentary inquiry into type 1 disordered eating, and I always learn a lot from Rose, and I'm just absolutely thrilled to introduce her. So Rose, over to you.
Thank you, Hilary, and good morning, everybody. Yeah, it's amazing that we've got so many of you joining in. I hope that's not just because of the horrible weather outside. It's still freezing and quite snowy here, but it's lovely to see so many of you right now. Here comes the moment of truth where I'm going to see if I can share my screen, and hopefully, there we go. All right then, so I'm going to be talking to you today about diabetes psychology and how we can start to make it happen across the UK healthcare systems that we use. So my job is as a consultant clinical psychologist. So my role is within the NHS working in healthcare systems. And that can look pretty different on a day-to-day basis. So I work directly, particularly with young adults. So I work very intensely with a group of 17 to 25-year-olds within our NHS diabetes service, but I also do therapy appointments for a whole range of adults with diabetes. And so that's generally thinking about feelings about diabetes and that distress that diabetes can cause, working with that and trying to help with the psychological distress that it brings so that people feel more able to look after their diabetes and enjoy a long and fulfilling life. So I tend to step in where diabetes is either compromising somebody's psychological health or where other psychological issues are getting in the way of managing diabetes. So that's what I do when I'm doing direct work. But I also do a lot of what's called indirect work. So I work with the systems around diabetes. So that's things like training healthcare staff, doing research, doing consultancy, writing lots and lots of service documents. I'm going to be talking quite a lot to you about that today because I think that this is something that is really important for people with diabetes to know and to understand. So to begin at the beginning, the reason that I'm doing this talk today is because every single time I do a talk, either to people with diabetes or to diabetes healthcare professionals, the one question that I get over and over again is how can I get psychologists into my service? How can I access psychological support? And this is an issue right across the UK. There isn't a single area of the UK, apart from maybe one tiny area of Scotland, that seems to have this sorted so far. So we're very much at the beginnings of diabetes psychology and growing diabetes psychology into a meaningful workforce across the UK. And as Natalie was already talking about in her presentation earlier, we know that this is really important. We know that people with diabetes, and particularly people with type 1, experience a lot more distress. Things like depression and eating disorders are far more prevalent. And then we've got the other issue as well, that where people might have additional needs. So if you have a pre-existing mental health issue, or if you've got something like autism or ADHD or a neurocognitive issue or a learning disability, managing diabetes just gets so much more complicated. And I'm pretty sure for the vast majority of the people on this call, you'll have had the experience where you needed to access psychological support and it was either really difficult or almost impossible to come by. So we know that there's this big need. And this is really emphasised in the Too Often Missing report that Diabetes UK published back in 2019. So this was a huge, huge survey of tens of thousands of people living with diabetes. And 7 in 10 people said that they were feeling overwhelmed by the demands of living with their condition. And this is also an issue in parents and carers. It's so important to emphasise that parents and carers of children with diabetes also experience this distress. And what was really sad in this report is that 3/4 of people with diabetes who felt they needed specialist support couldn't access it. And that phrase, specialist support, is really important because we know that living with diabetes causes a whole range of additional psychological stresses that are outside the experience of people without diabetes. So we're not talking about anxiety and depression here. We're talking about really specific things like diabetes distress, which Natalie already talks about a lot, burnout, type 1 disordered eating, fear of hypos, needle phobia. Trauma is becoming a really key area of study. So this is trauma where someone might have experienced a really scary event related to their diabetes, maybe something like a DKA or a really severe hypo, but also recognizing that sometimes people can unfortunately feel traumatized by the experiences they've had within the healthcare system. So whether this was feeling really ashamed or told off in a diabetes appointment, and a lot of people that I work with have had some really scary experiences in pediatrics when they were little and maybe they didn't want to inject and felt like they got held down or something like that. Now, fortunately, as a healthcare system, we're becoming far more aware of this, and our healthcare staff are really working to address this. But particularly where people have had diabetes for a long time, you might have come through a system where the views of how to talk with people with diabetes, how to support people with diabetes were very, very archaic. This is before the language matters era. And so you might well have had a whole range of really unpleasant and scary experiences that then affect you later on in life. We've seen some really great advantages in tech coming through recently. So whether that's things like your Libre, your Dexcoms, your pumps, these are all brilliant things. Don't get me wrong, I'm not giving them back. I do not want to give them back. But we're also starting to become more aware, as we saw in the last presentation, of the effect of data, that it can really push us into a perfectionist, self-critical place. And this is something that we're only just starting to understand and explore. And then, of course, we've got some of the complications that come alongside diabetes, and coping with those can be really difficult. So these are all issues that you just get from living with diabetes. And unfortunately, the vast majority of people who need to access psychological support don't get that specialist input. They end up in services that are designed for people with anxiety and depression. And if that's all you're living with and you have diabetes, then that's fine, that's great, those will work for you. But if your distress is because of the diabetes, so many people have this experience of going to talk to a therapist, taking that step, which is a scary one, and then feeling like their diabetes isn't seen, that it's not understood. And of course, I know if you live with type 1, we can't compartmentalize diabetes. It's such a huge burden. It's such a huge part of your life. You can't just lock it away in a cupboard. And so it's something that needs to be in the therapy room. We need this specialist staff. And if we don't have it, we get this thing that's called unmet psychological need. And from a wider perspective, not just thinking about the person's distress, we know that this has a whole load of really nasty knock-on effects. So we know when people are distressed, it gets harder to manage their diabetes. If it's harder to manage your diabetes, you're going to have more issues going on. So whether that's DKA admissions, whether that's more hypos, whether that's looking at complications, all of this starts to then impact the system around the person. So this is distress for carers, distress for parents, for partners. And really crucially, this is what I always have to talk about when I'm convincing NHS commissioners, this stuff is expensive. So we know that when people are distressed, they start to have these issues with their diabetes management. That means that they need a lot more medical resource, they need a lot more increased MDT time, and they use healthcare a lot more. So we know there's a lot of evidence that shows that when somebody is psychologically distressed and they live with diabetes, their costs for NHS care go up by 50%. That's huge. And so psychological support for people with diabetes isn't just about being nice and getting people happy. This is about saving money and resources for the NHS as well. So what do we need? We need access to diabetes psychology, and I would like this to be universal for all people living with diabetes. And when you're talking about pediatrics and young adults, for their parents and carers as well. We need it to be accessible. We need people to be able to access this easily and quickly. This needs to be flexible. This shouldn't just be a 9 to 5, Monday to Friday. People shouldn't have to choose between work and therapy sessions. And we need it to be integrated. So integration is really important when we talk about diabetes psychology services. A lot of the time where we do have diabetes psychologists, they're often different buildings or different parts of the hospital, and they might not have that much to do with the diabetes team. What we're starting to see now is that when you integrate these psychologists into diabetes team, so in my service, for example, I share an office with one of our medical consultants, so he's integrated whether he likes it or not. And we run holistic young adult clinics. So when our young adults come to clinic to see us in Wrexham, they will be sitting in a room with me, the diabetes consultant, and our diabetes nurse. We sit together and we have this very holistic experience. So we know it simplifies things. It increases the availability and it increases safety. It means that I'm teaching the team about psychology, they're teaching me about diabetes. There's so much to understand about diabetes that we don't get as psychologists in our general training. So it's incredibly important to have this integrated role. And there's huge team benefits that we can start doing CPD, we can train, we can supervise, we can consult, and there's far more in the way of team support. And we know when our teams are supported, they are more able to support people with diabetes sensitively and compassionately. So who do we need this psychological support for? I would argue everyone, but especially young adults. When we look at services, there tends to be more provision for children with diabetes because the guidelines in paediatric services are a bit stronger. But the minute a person turns 18, there's this massive gap in provision. And when we look at the research data, we can see that young adults are by far the most vulnerable population of people living with diabetes when it comes to psychological distress. So we really need to get in there with the support, and we need to make it in a way that they feel comfortable to access, because lots and lots of young adults are very, very anxious on the inside and really worry about talking about this stuff. But that tends to come out on the outside as either not engaging or sitting there grunting at you instead of having a real conversation. So having this something integrated that's a normal part of their diabetes care is absolutely key. And in an ideal world, this is what we'd have right across the UK. This is something called the stepped care pyramid. So it's thinking about a whole load of different levels of intervention. So at the top here, you've got people with the most severe levels of difficulty. So people who are really risky, really distressed, and they might need more of a team approach where there's multiple professionals involved. And then as we get further down the pyramid, this is where we start looking at what we're calling health promotion, this psychologizing the system. How can we make routine diabetes services a psychologically beneficial thing to access? So how can we get peer support in? How can we make education worthwhile? How can we make sure that all of our diabetes doctors and nurses help people feel good and not feel ashamed and told off and blamed? So this is really what we're trying to aim for across the UK. And where I work in Wales, we're starting to do that very, very slowly. So in Wales, we've developed lots of resources for people living with diabetes. We've got things like education programs for children. We've got education programs for young adults who are coming through services. And we've got a whole load of guided self-help books that we've written. So all of these are available across Wales, apart from this one, Household a Hedgehog, which is arriving in the next couple of weeks, and we're all really, really excited about it. So these books are all ones that we use both in paediatric and adult services. These two here are little kids' books. So these are sort of bedtime stories, but what we've done is we've snuck psychological interventions into it. And these are really, really nice. They've got a bit of art therapy going on in them as well. So there's 3 of these books that are also available in England. If you are in England and you haven't seen these yet and you are under a paediatric team, please go and ask your team. They should have boxes and boxes of these sitting in a cupboard somewhere. They might well have forgotten, so go and tell them to have a look. So we've got Burnout for Parents and Carers, we've got How to Manage a Mammoth, the little kids book. How to Manage a Mammoth is also available as a cartoon on DigiBete. So if you search DigiBete and How to Manage a Mammoth, there's an extremely cute cartoon that you can go and have a look at. But we need to think about how we get this right across the UK for everybody. In a magic world, I would just snap my fingers and I'd have an infinite money tree, but we know that that doesn't really happen. And one of the issues that is starting to come up over and over again is this lack of a workforce, that we don't have these specialist diabetes psychologists, and we really need them. There are published workforce guidelines, but what we really need to recognise is that when we're building these new services, that we need staff with seniority that can do this. So often services just buy in either little bits of mental health services or tiny bits of time where somebody might be only in the post for 2 days a week. That's not the fault of the diabetes service. They're very, very restricted in their budgets, but we need to recognise that we're building a whole new workforce across the UK with this. And this is where you guys come in. As people living with diabetes and parents and family members of people living with diabetes, we, as the diabetes psychologists, we need you, because without you and without your involvement, nothing will change here. Working in Wales, there are 2 people who made a really key difference to getting diabetes psychology commissioned in my health board. One of them is a woman called Wendy Gain, who heads up the All Wales Patient Reference Group, who took on diabetes psychology as a cause and would not let it go. Every single meeting she went to, every single health minister she spoke to, every single healthcare practitioner she spoke to, diabetes psychology came up as her issue again and again and again. We need you doing the same thing. Please ask, when you have your diabetes appointments, ask about diabetes psychology provision. Let your healthcare team know that this is a priority for you, that this is something that is important to you, because so often diabetes teams have got this misperception that if your HbA1c is in a good place and you're in work and things are kind of okay, that psychological distress just isn't an issue for you. You need to let them know that this is important to you. Even if it's not an active issue for you right now, please do start advocating for it. Please consider joining your patient representative groups. These will be present right across the UK, whatever hospital trust you're in. If you have got any time to volunteer, please do consider doing that. And also think about your local third sector groups. Diabetes UK Wales were absolutely key in getting my business case through for my health board, and they really advocated. The other woman who made a massive difference in my health board was a woman who wanted to access diabetes psychology and couldn't, because at the time we only had it up to the age of 18. She put in a massive complaint to the health minister on the basis of age discrimination, and our business case turned around very, very quickly on the back of that. So it is worth, if you have the time, if you have the energy, to consider advocating for this. Talk to your patient liaison service, talk to your MP, talk to the heads of your integrated care boards. They need to know that this is a priority, because if people don't talk about it, this is the issue with mental health, because it's something that often feels quite tricky, quite full of stigma. People don't talk about it, and if people don't talk, services won't listen. They won't understand that this is an area of need. Now, there's 2 documents that can be really helpful for this. Helpfully, one of these, the picture hasn't loaded. So the picture that should be here is a document called Missing to Mainstream. So this is a guidance document on how to commission diabetes psychology services. It tells commissioners everything they need to know. That document is available here on diabetespsychologymatters.com. The other really key document, especially if you're in England, is the GIRFT report. So the GIRFT report, which was written by Jerry Raymond and Partha Carr, makes really specific recommendations about young adult diabetes psychology. So it's well worth, if you get the opportunity, drop your health board an email and say, what are you doing to meet the recommendations of the GIRFT report? So please, without your support here, nothing will change. We need you. There are not enough diabetes psychologists across the UK to make this change ourselves. So please advocate for this. If you are somebody in a patient representative group, lead on this. Ask questions, hold groups accountable. Please do not let this go. There is absolutely masses of evidence that when we get diabetes psychology in place, it makes a huge difference for people's lives. So even if this is an issue that doesn't directly affect you right now, please consider doing this for you in the future, or for the kids who are going through this now. We need this support in place. So this is my plea to you. Please don't let this go. Please do advocate, and we can make diabetes psychology happen right across the UK.
And thank you so much, Rose. I hope for everybody that was really useful. Please do put your questions to Rose in the chat. Know that organisations like JDRF are pushing for greater resources, really making sure that that's the specialist system-wide support for psychological services in diabetes, because it is so important. But also, we can't do it without you. So it is the patient voice, it is that lived experience voice that really can transform and unlock that funding. So do put your questions into Rose. For resources, there are resources on JDRF's website, and I'll come on to DigiBete, which have a whole heap of resources as well. We'll go through that at a later point, but do put your questions through. So what I'd like to do now is then move on for just a couple of minutes. We're going to have 2 minutes from Insulet and then 2 minutes from Medtronic, and then we're going to have another comfort break. So moving swiftly on to Insulet. Thank you very much.
Yeah, I was double muted. My apologies, Hilary. Thank you for pointing that out. Good morning, everyone. My name is Helena, and I'm going to take you through the OmniPod Dash system. So I work as an OmniPod specialist here at Insulin, and the OmniPod Dash system is a tubeless insulin delivery system. The system is made up of 2 components, the pod itself, which is attached to the body, and then a handheld device that we call the Personal Diabetes Manager, or PDM for short. So you can see here on the screen, these are our pods. You can see it's a small, lightweight product and can therefore be worn anywhere you could inject. One of our biggest benefits is that the pod is waterproof, so you can confidently swim and bathe with no need to disconnect. The cannula goes in through an auto-insertion process, where a soft, flexible cannula is inserted after a tap of a button on the Personal Diabetes Manager, and the pod itself contains a 200-unit reservoir that can hold insulin for up to 72 hours. Now, each pod also comes with its own syringe and needle, which you can then use to inject rapid-acting insulin into the fill port on the back of the pod itself. Now we're going to have a quick look at our touchscreen or smartphone-like handheld device, which I mentioned is called the PDM. This device has many features, including a bolus calculator, a zero basal rate for those with low insulin requirements, the ability to set basal rate fractional insulin to carbohydrate ratios, and we also have incorporated a pod site tracker to help you with pod site rotation. Here at OmniPod, we also run something we call a support program. I'm part of the OmniPod specialist team specifically set up to help answer all of your questions about the OmniPod Dash system. So to find a little bit more, I would encourage you to give us a call and check out our website. As a part of our mission to ensure that you're able to make an informed choice, we also send out free sample pods, which you can get through the website or by giving us a call. For your conveniency, because it's a short presentation today, I'll pop that information in the chat as well, and feel free to ask any questions in the Q&A. Thank you very much for having me.
Thank you, Helena. And a couple of minutes, I'd like to pass over to Rich at Medtronic. Welcome, Rich.
Thank you, Hilary. Good morning, all. Shan Khan and myself are both here from Medtronic and are supporting the JDRF with mental health and diabetes awareness today. Please reach out to either of us in the Q&A with any questions you may have, and we will try our best to answer or direct you to where you can find the information you need. On each page, you will see a QR code you can scan with your phone, and we'll take you to the Medtronic site for more information, and there's plenty there. A quick overview of Medtronic diabetes in this short time. We have over 30 years experience dealing with insulin delivery and diabetes management, and over the last few decades have introduced life-changing technology and will continue to do so. There are thousands of people using our pumps and sensors to successfully manage their diabetes. Firstly, though, I will cover an area that may be of interest to you, particularly with this topic, to potentially give you more of your life back and actually free up the amount of time spent thinking and calculating your carbs and doses, etc. Here we demonstrate a typical user of a pump without CGM and the number of activities needed to think or process the management of their diabetes. Quite a few points to keep you busy and distracted from your everyday life. You can see diabetes plays a huge role in your daily life here, and much of your time is spent calculating your carbs and checking your glucose regularly. There's so many there. Moving on to a user who now has one of the first advanced hybrid closed-loop insulin systems, the MiniMed 780G system with SmartGuard technology. You can now see how the number of touch points is greatly reduced, allowing for more freedom, easing the pressure when managing their diabetes. The system anticipates, adjusts, and corrects every 5 minutes, giving you more control with less effort. And finally, we would like to introduce Medtronic's latest reservoir set, which is the first and only infusion set available, designed for twice the wear time to reduce the number of set changes by half and give your fusion sites more time to rest. You can find more details via the QR code, as said, for more information, or ask Shan and myself directly with questions on the QR. I hope this has helped, and I look forward to hearing from you. Thank you. Thank you, Hilary.
And thank you. Please do put your questions through. We're going to take a break now. So it is 11:31. So I suggest we come back at start at 11:40 to give everybody a bit of time, and we'll kick off with DigiBete, who've got a whole wealth of knowledge and digital resources. So look forward to seeing you at 11:40. Thank you very much. Hi everyone, welcome back. I hope everybody had a great break. I hope everybody's finding this webinar really useful in terms of the range of information around living with type 1 and mental health. I'm thrilled to introduce Maddie Julian, who leads and founds DigiBete, which is the online type 1 diabetes resource and information support platform supported by NHS England across so many different clinics with a wealth of resources. So without further ado, Maddie, you and I, we work in great collaboration, JDRF and DigiBete. I'm thrilled to introduce you. Over to you.
Thank you very much, Hilary, and really lovely to be here. And thank you again for the opportunity to share. I'm just going to put my slides from the start, so hopefully you can see those slides today. It's a real privilege to be with you today to talk to you about the work we're doing, but also the work we're doing in collaboration and with thanks to JDRF and the support that they're providing. So DigiBete is proudly supporting children, young people, young adults living with type 1 diabetes with thanks to the National Diabetes Programme and also the NHS Scotland and the Welsh Government. DigiBete have been working for a number of years really to try and solve some of the problems that families face around digital peer support, middle of the night support, and really the diabetes around the clock, which impacts so much on our mental health. I'm proud to say DigiBete has now got 74% of young people in England and Wales, and we're now going taking a lead across Scotland as well, taking up the app and using it to help with some digital peer support, some emotional wellbeing support, and also to enable everybody in families access to essential care guides, sick day rule support, and age-appropriate structured education, and also more communications from diabetes teams, because we know that diabetes is so complex, and one of the reasons why families really struggle with mental health and diabetes distress is just the sheer amount we have to learn. And I say we because I'll come to my story a little bit and I'll touch on that. DigiBete is made by families for families, and I think that's really important for people to understand every step of the way. It's made by different users and experts by experience, and coming together with clinical teams to try and help support young people and families' mental health. So we are, I'd just like to also acknowledge that we have some support from industry as well, who help us with getting out information around technology to assist in mental health and support. And we know that sometimes that also can be complex and challenging too, as we've acknowledged. So I thought I'd start actually by framing today where JDRF and DigiBete's aims are in terms of coming together to support our community. So I'm just going to share a slightly shortened version of our aims video, just so everybody can see where we are actually coming together.
I'm Karen Addington and I'm Chief Executive of JDRF UK.
Hi, I'm Dan Farrow, Head of Community Engagement at JDRF UK.
Hi, I'm Maddie Julian, and I am CEO at DigiBete.
I'm Rob Julian, Creative Director and Co-founder at DigiBete.
There has never been a greater need to provide young people and their families with extra support and information about how to live well with type 1.
I'm delighted at this new collaboration between DigiBete and JDRF. The two organisations have been working closely together for many years.
Both organisations led by people living with type 1 diabetes, and we are passionate about serving our community.
DigiBete are so proud to be working in collaboration with JDRF UK. Together, our organisations are going to improve the lives of thousands of families and young people living with type 1 diabetes.
So two disclaimers there. The first one is to say that I no longer have that tan that I had last year when we made that. And the second one is to say, in all seriousness, the challenges for families living with type 1 really start with the fact that we're not bringing up little adults. Our children are not the same as adults, and the challenges are different. And it's not to say the challenges are not just as difficult for adults, but they are different. And the way that children learn and interact is different. And as a teacher by background, and also a mum of a young person with type 1, we saw that quite evidently in the hospital and the kind of on initial diagnosis. And we saw an opportunity really to improve what we provide for young people and families. But we don't stop, and it's a constant iteration of what's good, and we're constantly looking at what's next and how else we can support. But to start, I thought what would be really useful for those of you who aren't aware of what we do is to show you around our app, because I think it'll give you a good flavour of what DigiBete actually provides young people and families now. So just play this.
Once you've set up your DigiBete app, you're ready to use it, and it will help support you with essential information to help you manage type 1 diabetes. The homepage has lots of different areas for you to explore. There are top tips to help manage blood glucose levels. There are films to watch, and you can favourite the ones you like, and they will appear on your homepage, making it easier to access. You can access all your clinic's information on the My Clinic area, including team members, contact details, useful documents and links. There is an age area where you can learn about type 1 and support your emotional well-being and all the things you need to know for your age, as well as a quiz area, so you can test your knowledge after watching the videos. You can receive updates from DigiBete and your clinic in the news area, and there is an awards section which shows your progress through the app. A searchable dictionary is also available in case you need to find out what something means. By clicking the button in the middle of the home screen, you'll have access to essential care videos. And by clicking the play button at the bottom of the screen, you'll have access to diabetes tech guides and information pages, carb-counted recipes that you can try at home, information on managing food around cultural celebrations, and a range of sports and exercise films ranging from managing active toddlers through to competitive sports and everything in between. The My T1D section is a place where you can store your own information about your type 1. You can track your HbA1c and time in range. You can add appointments which sync to your phone's calendar, or your clinic can send you appointment reminders and messages direct to your app. There is information on sick day rules. You can make notes or even voice notes to help you prepare for your clinic appointment. You can store your insulin to carbohydrate ratios and correction doses, and your long-acting insulin. And if you use an insulin pump, then the basal rate can also be stored with as many intervals as you need. There is space for your total average daily dose, and a place to store and view your digital school or college healthcare plan. On the settings cog, choose My Account, and then you can choose to opt in to sharing award information with your clinic. You can also choose preferred language. Your clinic's contact number is always there in case you need to get in touch.
So we know that diabetes is complex, and we need lots and lots and lots of support, and DigiBete are set up really to try and support in as many ways as we can to just make diabetes a bit easier, and that is what the app hopefully will show you. Sometimes it's about solving the practical issues of needing support in the middle of the night and watching a glucagon injection, and sometimes because you're suddenly at that stage. And actually just a couple of weeks ago we were literally at that moment when we had to open the orange box, and we thought we needed that recap, and lots of families will talk to us about that. But it's also about being able to see others living with diabetes and have that digital peer support, which is all available. And for some young people, DigiBete's helped them come to terms with the diagnosis, seeing others and feeling not alone, and being able to understand what it means and share with others without having to always talk about it, but show them a video and say, this is what diabetes means to me, or this is what diabetes is really, really helpful. So I did speak about our journey, and our journey began in the wonderful Leeds Children's Hospital. So we had amazing care, but like a lot of you, we really struggled. And actually, it was only when we had a small group session with a psychologist that I started to process what was really going on, and we were talked through the cycle of grief and what that meant. And actually that suddenly clicked with me, and I realized that all these emotions we were having were sort of verified, if you like, and ratified, and said this is actually okay, and this is normal, and this is a process. So giving people permission to be able to feel, you know, and to be able to talk about diabetes distress is just so important. And we at DigiBete and JDRF really believe that that's so important, and we want to enable that more and more. Living well with diabetes is really important, but we also need to acknowledge that it's difficult, and it's difficult for everyone, and it's still difficult for us at times 7 years on. We now have an 8-year-old who doesn't really want it now. So, you know, so these are sort of, you know, the issues that happen. So what have young people told us? Well, I'd like to just share with you now a montage of young people talking about what diabetes means to them in terms of their mental health and their emotional well-being. And I think this is really a really good place to start with how our collaboration with JDRF is going to look to improve some of this.
So I'm Jordan, I'm 20 years old. I was diagnosed when I was 18, and I'm a type 1 diabetic. I'm Stacey, and I've had type 1 diabetes since I was 2, so about 15, 16 years now. I'm Georgina, I'm 23, and I've had diabetes since I was 3. When it comes to type 1 diabetes, for me anyway, there is no such thing as a normal day. Every day comes with its own challenges and its own obstacles. So I really into photography. I've done taekwondo since I was 7 or 8, and going to the gym as well, that really helps a lot mentally. It helps me get like my anger out. It was quite difficult to get my head around because I've been used to not being diabetic my whole life. I think one of the biggest challenges that I face as a diabetic is the pressure that I put on myself to be perfect all the time. And one of the things I've learned is that you can't do it right all the time. You can't do it right all the time, and that's okay. But I really struggle with looking at what I've done and the mistakes I've made rather than focusing on the positives.
You meet a lot of different people with different responses when you tell them you're diabetic. Some good, some not so much. Like, I'm really lucky to have some real supportive friends. You know they'll be there for you if you need them. And that's the kind of people you want to be around. It's good to have like reliable people.
You're constantly looking after yourself and you're constantly aware of it, that sometimes it just becomes a lot. And I find it really tricky to like make myself do it.
Okay, I'm going to just move on from there because you can see those videos on the site, and I'm just aware of time, but want to say that there's lots of, if your young person is dealing with sort of diabetes distress or would like to see other people living with diabetes, please do access DigiBete either on the app or the website. And if you type in emotional wellbeing, you'll get the emotional wellbeing resources come up, and you can watch those films and see other young people also having that challenge. Rose also mentioned the Mammoth today. I'm not going to play this for you, but just to say that there's a QR code there if you would like, and I've put it in the chat as well. The Mammoth is a very practical resource written by Rose, and will help you. Will help your young people, but also I think adults love it too. It's just a bit of it's sort of a different way of thinking and framing your thinking around type 1. And now I'd just like to talk to you really about the new psychology platform that we're integrating with DigiBete through the work we're doing with JDRF. And this is in the early stages at the moment, but it's just worth sort of acknowledging that this is, you know, what we're doing. So we are looking to put in, and it probably won't be called self-care because this hasn't been through young people yet, and I'm sure young people will name it something quite different. But initially we are looking at creating a resource, first of all, for 10 to 14-year-olds as a feasibility study. And within that, we're going to be looking at some really practical, evidence-based tools to help young people with managing their feelings of isolation, potentially family conflict. And again, these words will change because young people will have their own steer on what they might relate to in terms of some of these areas. And we're developing this with a group of psychologists, clinical psychologists across the National Diabetes Network. We've got a sort of a steering group as well with older people with lived experience and also younger people's workshops. And this is really interesting because this came about because a family came to JDRF to say that they really would like to see some practical support for acknowledgement really around psychology and scaling psychological support, and we couldn't agree more. It's just so important. So what we hope to do is give everybody a little something, and in the next phase of this project, we'll be looking to do this for parents too. And I know there was some discussions in the chat about parent support. And also there's been on Twitter, there's been some conversations this morning about evidence around the need for parents as well. And absolutely, everybody needs a bit of something, but it's a huge area. But it's just to say that our eyes are on it and we know we're going to do something really magical in this area together. Thank you for listening today. I know that I'm probably just about at time, but there is a survey that you can take. We'd love to know how you feel and what you would like to see. So if you want to do this, if you want to scan the code and take the survey, it's only about 6 questions. Very, take you a couple of minutes, but we would love to hear that. I'll put the link in the chat as well in a moment for everybody. But watch this space because there's going to be some really, really interesting developments around this to support young people, and we'll be evidencing it. So we'll look forward to reporting back at a future Discovery Day. Thank you.
Thank you so much, and I hope there are lots of resources that will. I think one of the things that sort of we draw out as a common trend across that is whether it's Natalie in the research or Maddie in terms of DigiBete or JDRF, and we're going to hand over to Chris. There are so many people in this sector who live with type 1 and who are working and striving in the field of mental health, in the field of research to prevent, treat and cure. So for us, this is personal. Our mission is personal, and there's a lot of lived experience from staff, from researchers, from organisations like DigiBete with that deep lifelong experience of what it's like and why we need to change things. So I'm going to hand over now to Chris, who's a member of our staff here at JDRF, who's going to be talking about mental health and living with type 1 in terms of a male perspective. Chris, over to you.
Hi Adam, welcome to the JDRF Type 1 and Mental Health virtual event. Just before we get going and having the conversation, do you want to just briefly introduce yourself, your connection to Type 1 and why this subject is in particular one that you wanted to talk about?
Yes, mate, Brycey, how are you? Good to join you again. I know that we've linked up in the past. So yeah, my name is Adam Smith, or most people will know me as Smithy in the industry. I am a presenter for Sky Sports. I also do a bit of work for England and for Tottenham Hotspur as well, but predominantly you'll see me on your screens on Sky Sports. And my link with JDRF is an obvious one. I am a type 1 diabetic. I've been type 1 now for 8 years. And quite a brutal diagnosis, to be honest. It was found quite late and the usual symptoms were there. I rushed to hospital, told I had type 1. So yeah, and what I found from diagnosis was that obviously the physical side is a big challenge, but I also found that mentally, my mental health plummeted, to be honest, quite a bit, certainly for a good few years afterwards. And since that difficult period in my life, I would describe it as, I'm in a lot better place now with my physical and my mental health, and I've since become an ambassador and then an honorary patron for JDRF. So I do a lot of events such as this one. I host a lot of the balls that they do and quizzes and bits and pieces. So I'm a big passion project of mine is to give a lot back to the type 1 community and do a lot with JDRF. I'm proud to be involved in the charity and a lot of great people that are involved within it. So in a nutshell, that is my link to type 1 and to JDRF.
And a big thank you for all the support, Smithy, that you give to the charity and to all of us with the raising awareness of type 1. With the event then, we're obviously talking around that subject of mental health. So what do you feel the impact of living with type 1 has been on your mental health? Where do you feel it's maybe had a part to play in how you think or how you feel going through life?
Yeah, my diagnosis has had a massive impact on my mental health. For 2 years, I pretty much kept the condition bottled up, used to inject in private. Other than my close family and friends, didn't really speak to anyone about the condition, which was the worst thing to do and the worst bit of advice I could say. That, you know, for anyone newly diagnosed, I would say, and I would highly recommend that you let your friends, your family, your work colleagues know, because obviously if you are having a hypo, or if your bloods are high, or you've got any issues with the management of your condition, you need others to help you and to understand the condition as well. That's the key thing. It's a very complex condition. I didn't have a clue about it prior to diagnosis. And so I shouldn't expect other people that don't have the condition to know what to do if my bloods are low and what to do if my bloods are high. So that's the first thing I would say. But I feel like there is so much education and resource into, you know, your Daphne courses, your carb counting, your how to keep your insulin at the right temperature, the when to inject, where to inject, how to inject. But what I found is that actually it has a massive impact on your mental health. And I personally didn't receive any information or education about actually how this can impact my mental health. As I say, I went on all these courses about carb counting and everything like that, which is important, of course. But what I've found from chatting to a lot of fellow type 1 diabetics on social media and since my work with the charity is that so many of them have mental health issues. You know, I've seen the statistics. You're way more likely to suffer from mental health conditions if you have an autoimmune condition. That is just a fact. So in terms of mine, yeah, I kept my condition bottled up. I had dreadful anxiety. I actually went to see a specialist, a private specialist, to have a brain scan, to have balance tests, because my dizziness was so bad after diagnosis that I was convinced I had something wrong with my brain or my inner ear or my balance. Had all these tests done, including a brain scan, including seeing a specialist neurologist about all sorts, and nothing other than being a type 1 was adverse. And I was told that the dizziness was a direct result from the anxiety that I was suffering. So once I received that, and also once I opened up on social media and spoke to friends and family about my diagnosis, the fact that I'm a type 1, it was a huge weight lifted. And from that moment onwards, I've found it not easy, it's never easy, but easier to manage the conditions. So yeah, for years I was keeping stuff bottled up. I was, you know, in bits at night. I was unable to switch off from the condition. And I've found that the biggest catalyst to change in my mental health has been speaking up, talking to people, being involved with charities, and just speaking to fellow type 1s is a big one for me, because they can understand what you're going through. So I think talking has been a huge case. But I also find with mental health, and I do a lot in this space with other charities as well, and a lot of content that I present and produce in this space as well, is that you don't either have good mental health or bad mental health. It's like a spectrum. Everyone can have good days and bad days. And when I say I'm in a good place, sometimes people go, well, glad that you're better now. And it's like, well, I'm currently in a good period. I might have a dreadful week next week with my blood sugars, with my mental health. I don't know. I'm just saying I've learned to coping mechanisms and strategies that help with my mental health. So I think that's the key, is to not categorize mental health as this person suffers from it, this person doesn't. It's a scale that everyone is on a scale. Everyone can have good days and bad days. And also, I might have exactly the same issue as you do, but you might handle it differently to I do. Everyone is different. So I think it's just about understanding that. Talking is a massive one for me, and just knowing what works for you in order to help with your mental health. That's what I've found has been a big positive change for me personally.
Yeah, and I can hear a lot of myself in what you've said there, especially about keeping things hidden, and then the pathway and the journey then to opening up and talking to people, and how that weight feels like it's lifted and made it just a little bit easier to live with type 1. Not that it ever gets easy, but kind of just helps you on that path and that process to, seeking out new opportunities to improve as well, and get support from others. Do you think, as a man, there's anything in particular about male culture that sort of impacts on our mental health, specifically around type 1, that you would maybe lean towards as having an impact on you as well?
Are you talking about the perception of males particularly to speak up and things like that?
Yeah, opening up, the kind of potential of sort of showing no weakness as a man.
I think it's a good question. I mean, I do a podcast for a mental health charity, actually, and the statistics we give out are are really sad, actually. Obviously, it's one of the biggest killers of young men is suicide, and the percentages of people that complete suicide, it is skewed massively towards men. I mean, it is a shocking statistic how many. I think I'm right in saying something like 75% of all suicides are male. I think it is the biggest killer of men between the sort of teenage to age 40 years. Which, when you think of how difficult life is and how many conditions there are out there that people suffer from tragically, that to have that as that takes so many people's, male and female, it's worth pointing out. But in answer to your specific questions about males, it is tragic that the suicide statistics are so high. Yeah, I definitely think it's interesting that you mentioned that, because from chatting to fellow male type 1 specifically, in answer to your question, a lot of them say that they struggle to open up. You just said it to me now. A close friend of mine said it to me. I struggled with that. And I think women are, without generalizing, are better at opening up and chatting about their feelings and supportive in that way. There is an old school perception that chatting about your problems was perceived to be a weakness. I use the word was because I think we're getting a lot better now at talking. And that's why I do so much in this space. And I've gone from a period where I didn't want to talk about anything and hide my condition, to now that, you know, I can't talk about my condition enough. I do day in the lives of a type 1 on my social media. I've told my stories to national newspapers. I've fronted features for Mental Health Awareness Week on national broadcasters and things like that. So I'm at a stage where I want to talk about it as much as possible, in the aim to, if I just help one person, then that is job done. But I certainly think we are moving in the right direction. And I think that if anyone is struggling, as I said, talking is the best thing, and there should be no stigma or negativity associated with speaking out. And perhaps maybe years ago, many men and many women maybe as well would have thought speaking out was perceived to be a weakness, whereas I actually think it's a massive strength to say to someone, do you know what, I'm struggling, can we sit down and talk? And in my experience, and it might not work for everyone, but that's always helped me in the past.
Yeah, definitely. I think as a male, I've found that challenge to be the hardest part, I think, of living with type 1 is coming to that
out?
Yeah, coming almost like, you know, the word like coming out, that conversation of like acceptance of what you're living with and sharing it openly, because it almost then opens you up to the opportunities for how to manage it better and take in more information. I think I found it the hardest keeping it hidden, but I was hiding it because actually it was the culture maybe that I was surrounded by, or what, you know, that what you said there, Adam, about old-fashioned views of like not being able to share or feel that you could open up to other men or other people about what you were thinking and feeling as a man. I think it closed me off to the opportunities to do things better for my condition and to manage things better. I don't know whether you resonate with that or not.
Massively, yeah, massively. That's one of the hardest parts for me as well, is that, which is crazy when you think of how difficult the condition is. I'm not going to sugarcoat it, because there's a lot of people watching this that know exactly what living with type 1 is involved. Sorry about that pun, sugarcoating. When I just realised we're talking about diabetes there, so it's a dreadful, unexplained and unintentional pun. But yeah, but I don't want to sugarcoat it, because it is a very difficult condition. It's every day. It's relentless. It involves so much, and you know, I find I speak to even healthcare professionals, and when they don't have the condition, I still find myself battling with healthcare professionals about my condition, when I feel like saying, well, with all due respect, unless you've got the condition, I don't think anyone can fully understand it. And that's not a negative on anyone, but unless you live with it, it's very difficult to explain. So it is a relentless condition. I'm not going to pretend it isn't, and I'm not going to pretend that I don't think that, oh wow, potentially I've got this for the rest of my life. We don't know whether a cure or any steps are close in that aspect. You never know what the future holds. But yeah, it is relentless. And to think you have to do this every day for the rest of your life is tough. But what I would say is technology's come so far. You know, there's a lot of ways that make managing the condition a lot easier than it was. And I think people are becoming better educated and more understanding about the condition. And I think we have come a long way. And I think, going back to what you said, it's interesting that with all those difficulties, that isn't it mad that both myself and yourself, one of the hardest parts was talking to people. When you think injecting, carb counting, carrying all this with you, like hypos, all of that, which is so difficult. And we both said that actually telling people what we've got was the hardest part. When you actually compartmentalize that's crazy. That should be the easiest and most supportive part, but it isn't. And it's something that many fellow type 1 diabetics many fellow type 1 diabetics say they struggle with. And it's a big thing that I want to change, is the stigma and the education and the understanding about it, because that should be one of the easiest parts, but it is unfortunately something that a lot of people struggle with because of the complexity of the condition. Do you find as well, Chris, is that because it's injecting and because it's a bit out of the norm and in public and stuff, that when you were diagnosed, you didn't want to talk to people about it because you were seen as different? Did you find that?
Probably the most challenging part of growing up with type 1 was the physical demonstration of difference that injecting insulin put upon me in different social environments, whether that was at school or whether that was in football teams. I always used to hide injecting so I could almost blend in with who I was around, and because of that I got so used to hiding it that then you become used to hiding everything about what's going on inside, because you're constantly trying to fit in with what's going on around you. I think that has probably formed some of my biggest challenges with talking about the condition, is that need at the start to hide living with type 1 diabetes, because I felt that was the right thing to do, because it always pointed me out as different because I was injecting insulin. And there's because of the nature of the condition, you can go in and out of looking type 1 like you live with type 1, because you will only inject for a few seconds. You'll only need to finger prick test, if we're going back a years, for a few seconds. The rest of the time you can look like everybody else. And it was those points of difference that I really struggled with. I didn't want to show people that, because I'd learned from my social environment that actually difference wasn't embraced that well. And that's the impact that it had on me.
I mean, it's amazing, because it's something that so many type 1s can resonate with, and I think that's why conversations like this are really important, to normalize the conversation and also normalize the situation. I mean, there should be nothing wrong, or we shouldn't feel anything negative towards injecting yourself in public to keep yourself alive, really, is the long and short of it. So I think conversations like this hopefully can only help that.
I couldn't agree more with you. And I mean, for this event in particular, it was just an opportunity for us to have this really short conversation and open up different areas and just have that chat around where it specifically might impact on us as men and living with type 1. So I just wanted to sort of round it off with what would be your kind of key tips for how you keep on top of your mental health whilst living with type 1.
Mental health specifically you're talking about, or diabetes?
I mean, you go with both if you want.
So I mean, if I look at it, I definitely look at my life in two parts, sort of pre-diagnosis and post-diagnosis. I mean, it had as I said, dramatic effect on my, well, obviously physical health, because I was really unwell at the time, but also a dramatic effect on my mental health as well. And obviously, and I've not just experienced really negative mental health within my life, but I've done a lot of reading and education and research on it. It's a real passion topic of mine. And one thing I would say is you've got to work out what works for you. So it's all very well to say someone go to the gym or talk to people. You might not like the gym. You might like to keep things to yourself. What I've personally found, and I'm not an expert, but what I've personally found is finding something that gives you pleasure or enjoyment, whether that's going for a walk, going to the gym, is massive for your mental health. If you're just sat inside, you know, and we all found this during the pandemic when we had to be inside, and it was very difficult for many people. But you know, there aren't restrictions now. And if you're just sat inside, it can feel like the walls are closing in on you. You know, getting fresh air, going for a run, going for a walk, all of those things I'm a big advocate of. For me personally, again, opening up and talking to people has been absolutely massive for my mental health. You know, I went from bottling up my conditions to tearing up at night, to not wanting to burdening people with my issues with my mental health or my type 1, to actually, the more that I spoke to friends and family, the more they were there for me and the easier it was for me to understand it. So I definitely say talking is a big one. I definitely say find a hobby or something that you're into that is an escape from your 9 to 5, from your everyday, from all the stresses that, you know, life is complex. It's difficult for everyone, of course it is, but finding something that gives you enjoyment, you know, putting something in the diary when you meet up with friends, even if it's going to the pub or going for a run with your mate, having something to look forward to, a little hobby that you enjoy, and talking out, I think you know, not rocket science advice, but little things that can really improve your mindset. And they're things that have worked for me in the past.
Brilliant. Well, thank you so much, Smithy, for joining me in this conversation. I hope the community that have joined us today have taken a lot from it, and I hope that this continues to open up the conversation around mental health, and specifically amongst men living with type 1.
Yeah, thanks, man. Like, all I'd say lastly is, you know, if people are struggling with whatever it is, it's a real strength to talk out, not a weakness. And there's loads of support networks out there as well that I've found personally have been very useful. So yeah, talk to people and stay positive. And it was really good to do this, mate. I'm a big advocate of all things type 1 and mental health. So mate, great to chat to you. Hopefully catch up soon.
Top man, Smithy.
Cheers, mate.
And thank you ever so much to Adam Smith for that, and the conversation with Chris Bright. And there's a really interesting element about how this is a hidden condition, the element of stigma, but also the importance to be able to feel open and to be able to talk about it. I'm going to move back to Natalie now to talk about body image and eating disorders. And one of the things that we've been invited to do by Theresa May, former UK Prime Minister, she lives with type 1. She is our research ambassador. She's aware that there's a huge issue around type 1 eating disorders, and she and a fellow parliamentarian called Sir George Howarth have come together to do a parliamentary inquiry into type 1 eating disorders, and we're doing the support, report writing, evidence sessions, etc., etc. So we really want to put Parliament's spotlight onto mental health and type 1 diabetes. Without further ado, I'm going to introduce you back to Natalie, who's going to be able to talk more about type 1 diabetes, disordered eating and body image. Natalie, welcome.
Thank you so much. It's great to be back, and I hope that my audio is a little bit better this time around. So to anyone who's just joining, I'm Natalie Zaremba. I've had type 1 diabetes for 18 years, and I work at King's College London as a researcher in type 1 diabetes and psychology. And a big part of my work in eating disorders is on a project called STEADY. And I'll be talking a bit about eating disorders and body image in diabetes in general today, and also focusing on some of the research that we've done in the STEADY project and the strategies for recovery that we've found by doing research with people who have lived experience. Next slide, please. And so I want to kind of preface this presentation just by saying that I'm a researcher and I'm not a clinician. I'm not a doctor or psychologist. And so all of the work I'm presenting today is supported by a great team of researchers and doctors, psychologists, and people with lived experience. And so you're very welcome to ask questions, particularly about the research I'm presenting. Please do put them in the Q&A or ask us in the lived experience panel, and we'll answer the best that I can. But please do keep in mind that I can't give any individual medical advice. Next slide, please. So to start off with a bit of background for people who maybe aren't as familiar with type 1 diabetes and disordered eating, which we also call TIDE. As I mentioned in my previous presentation, eating disorders are twice as common in people with type 1 diabetes than in those without. There are a lot of different disordered eating behaviors that people can experience, including insulin restriction. So some research estimates that up to 30% of people with type 1 restrict some insulin, but many people with diabetes also experience other disordered eating behaviors, such as binge eating, restricting carbs or certain food groups, purging behaviors and over-exercising, and even following excessively rigid diets. And a lot of eating disorders are not really noticed by healthcare professionals, and they're not picked up. Even sometimes people with diabetes don't realize that maybe their behaviors might not be helpful or healthy for them, because managing diabetes actually requires some disordered eating behaviors. We're told to count carbohydrates and measure and weigh our food so that we can appropriately dose our insulin. And we're told that this is good diabetes management. And so it's really difficult for clinicians and diabetes teams to pick up on disordered eating a lot of the time. And eating disorders often lead to higher rates of diabetes-related complications, diabetes distress, And there's currently no effective and evidence-based intervention for people with type 1 diabetes and disordered eating. And that's mainly because existing eating disorder treatments aren't compatible with diabetes management, and they don't address the specific diabetes-related issues that people with TIDE face. So most eating disorder treatments focus on moving away from counting carbs and calories and reading food labels, but of course we need that information. And in addition, eating disorder teams don't have the training in diabetes and don't feel comfortable helping people with diabetes. And diabetes teams aren't given training on how to manage disordered eating or providing psychological support. And so often people struggling with disordered eating and type 1 fall kind of through the cracks between these different healthcare providers. Next slide, please. There are a lot of different factors that contribute to disordered eating. Counting carbs and focusing on the food you eat, measuring and weighing food. There's language like uncontrolled and compliance and fail, which often lead to feelings of shame and stigma and diabetes distress. There's a lot of pressure to have perfect diabetes management and fear of complications. People are often weighed at each diabetes appointment, which can increase body dissatisfaction. And most people experience some weight loss before diagnosis, which can be really difficult. Some people have disordered eating before they're diagnosed, and that makes their diagnosis and this focus on food and carb counting and all of this more difficult as well, and learning the management of diabetes. And as we know, diabetes devices and paying close attention to your body's sensation, looking out for hypos and hypers, ignoring your actual hunger cues, like when you have to treat a hypo and maybe you're not hungry. All of these different things and many more contribute to disordered eating and body image in type 1 diabetes. Next slide, please. So our team has done a lot of research into the experiences of people with TIDE and how eating disorders develop and even how people have recovered. In 2018, we published a paper that analyzed blog posts written by people with TIDE to understand some of their experiences. And we followed that up with a research with an interview study where we spoke with people with TIDE and people with type 1 diabetes who've never had an eating disorder. And we use those interviews to develop a model of kind of maintenance cycles of how TIDE develops, what some of the risk factors are, as well as what some of the protective factors are. Next slide, please. And I won't go too far into all of the details because you can see that there's a lot of different arrows pointing from one aspect to the other. But just to give you kind of an idea of the main things, we found that kind of people's experiences at diagnosis, having positive or negative experiences with that initial diagnosis and what that was like can impact people's experiences with disordered eating, their relationship with food and body image, their overall physical and general health. It includes people's reactions to diabetes and their social experiences, and predisposing factors like a previous eating disorder or having high perfectionism. And so you can see that these relationships are really complicated, and it makes sense that body image and eating disorders are so difficult to treat when so much of it is intertwined. Next slide, please. So looking at some of the more detailed results of our interview study, which was called the Barriers Study, one thing that we found is that everyone that we interviewed at some point, whether or not they had an eating disorder or not, felt like this woman on the left. And the quote beneath it says, "I couldn't deal with the stress on top of diabetes. I couldn't manage it. I dropped the diabetes and was uncontrolled, and that made me really unhappy, but it was one less thing to worry about." And everyone at times has felt frustrated and angry and hopeless with diabetes sometimes. And I think that's really important to acknowledge that diabetes is hard. And I've said that before in my earlier presentation, and I'll keep saying it because it is really difficult and it's normal to be unhappy with it at times. The key that we wanted to look for to make diabetes management and recovery from disordered eating is to be more constructive. So the quote on the right says, "It's not as depressing to think about. I'm starting to feel confidence about what I'm doing and see more of a future living with diabetes." And this is the kind of goal for the direction of recovery for many people, at least in the beginning, to see a future that doesn't look perfect, but it's there and it's manageable. Next slide, please. So in our interviews, people described 3 main areas that impacted their disordered eating, and that was their relationship to their body image, their relationship to their diabetes and diabetes management, and their relationship to food. And kind of throughout all of these, perfectionism, pressure to have perfect diabetes management, wherever that came from. Sometimes it was healthcare professionals or friends and family. There was high expectations and feelings of failure and shame when they couldn't achieve some of these goals. And all of these are quite prevalent through these different areas. Next slide, please. So in our interviews, people often described these relationships with their diabetes, body image, and food kind of like a bickering old married couple. And so we used these images to kind of illustrate this. On the left, we have a perfect relationship, this happy couple feeding the ducks and smiling. And underneath, we have what this perfect relationship sounds like. I've embraced my diabetes. I love my body at every size. I'm happy with my relationship with food. It looks perfect. It has really high expectations, and it's not really realistic to look like this all the time. In the middle, we have a rejecting relationship. The unhappy couple not speaking to one another on the bench. They're saying, diabetes has ruined my life. I hate my body. Food ruins my blood sugars and my body. And this kind of relationship isn't helpful. It doesn't really make you feel good either. And on the right, we see kind of a functional, good enough relationship where you can see a future with diabetes. You want to take care of your body, and food is just a part of life, and you can enjoy it, and it doesn't have to be perfect. And this is the kind of relationship that you can move forward and have ups and downs with and be a little bit more manageable in the future. Next slide, please. So we used these interviews and these relationships and experiences that people have shared with us to develop the STEADY project, which is Safe Management for People with Type 1 Diabetes and Eating Disorders study. And the aim of the first phase was to develop a cognitive behavior therapy-based intervention for people with TIDE using experience-based co-design, and I'll get into that next. Phase 2 of the project is testing the intervention in a research trial, which is what we're currently doing. Next slide, please. So what is experience-based co-design? It is a research method where people with lived experience of a condition come together with healthcare professionals to design a service together. And this really distinguishes EBCD over other ways of involving people with lived experience, because the people there are equal partners in the process of developing the tool or the service. They're not just advisors or providing feedback, they're actively building the service together. So we facilitated workshops over several months with specific themes to address different aspects of recovery. Next slide, please. So we had a total of 40 co-designers involved with the development of STEADY, 15 people with lived experience, and 25 healthcare professionals with experience in diabetes or disordered eating. Next slide, please. And we had 6 workshops held from July 2019 to March 2020. The first 2 were held at the Bournemouth National Type 1 Diabetes and Eating Disorders Conference, and the other ones were held at a King's College London campus. And we did our best to make sure all of our workshops were accessible for people who wanted to attend. We held them after working hours so people could attend after work and school and other commitments. We're running short on time, so I will just move to the next slide, please, and get into some of the results. Each of our workshops had a central theme that we focused on, and participants could choose which sub-themes to be part of as well. These are our workshops for the six themes. Next slide, please. And this is just a quick example of what some of the activities that we had during the workshops. So the photo there is an example of a vicious cycle, and people could sit around the table and discussing these, the kind of maintenance model for this particular theme, and address ways to intervene and kind of put the post-it notes in different areas with different ideas of how this can be addressed and help guide recovery. Next slide. So one of the most common things to come out of the workshop was the need for personalized treatment plans that could be adapted for each person. And this led us to develop a study toolkit instead of a standardized therapy manual. This allows us to address each person's specific needs in a really individualized and flexible way that ensures studies relevant for them in their stage of recovery. A lot of the recurring themes included perfectionism, smart goal setting, really small changes, and the broader benefits of recovery. Next slide, please. This one is a kind of more specific example of the relationship to body image theme. And in the next slide, I'll show you some of the results that came from this workshop. Next slide, please. So in this theme, you can see some of the concepts we brought into the toolkit are the impact of diabetes devices on your body image, the idea that when you have diabetes, your body doesn't do what it should, and finding self-worth outside of body image. One participant says, I never wanted to use an OmniPod because I have enough lumps and bumps, thank you. And another one says that the eating disorder is a reaction to your body betraying you by not working. And you can see in the written comments on the left that this person could relate to some of the quotes that we brought in, saying that diabetes can come along and make existing problems worse, even if diabetes wasn't at the center of your body image. So on the right, we also have a screenshot of a comment from a toolkit exercise that we developed from this workshop. And the participant has kind of highlighted that these questions are helpful because they address them as a whole person rather than only focusing on the diabetes. So you can see how these workshops and the experiences of our participants provided some really powerful insights into the development of the toolkit and the intervention strategies. Next slide, please. So just to quickly summarize our results so far from our strategies, we used experience-based co-design to bring in the lived experiences of people with type 1, and it was really collaborative and made use of the experiences and strategies that people have used to recover themselves. This put everyone involved on the same playing field and helped develop innovative tools and strategies that have been used by people. And this kind of this helps study overcome traditional eating disorder treatments and therapies that don't work for people with TIDE. Recurring things that are really important for recovery are personalized treatment, slow and steady changes, and goal setting, and addressing the broader benefits of recovery to people's lives. Next slide, please. Just a quick thank you to all of the study collaborators and people that support the project and have had their input. Next slide. This last one. I know I've been focusing on the study project, but there are a lot of other important things happening in eating disorders throughout the UK. We have the Compassion Project that's happening in Wessex, and the priority study that's happening for preventing eating disorders in young people. And last slide. Thank you very much for the time and letting me speak, and I look forward to speaking to everyone in the lived experience panel later. Thank you.
Thank you so much, Natalie. And that focus on that research around sort of what the goal of having a relationship with diabetes is good enough. And it's not about perfection, but also supporting people not to burn out, but getting to that, and I'm going to make that pun again, that sweet spot about it being good enough, and to be able to be forgiving of oneself, and there to be the space to be able to grow and develop without feeling punished or judged or stigmatized is just so important. So thank you so much. I'm going to hand over to Chris now and our lived experience panel to actually be able to talk from that lived experience and a group of people who can talk very powerfully and with so much resonance. So Chris, over to you.
Thanks, Hilary. Yeah, great to be able to join and chair this chat now, this lived experience panel, and hopefully with some support from healthcare professionals as well. We'll take some questions, I hope, from the chat and Q&As as well, so do put them in there. And I will also direct questions specifically to those on the panel as we go through. So I'm going to be joined by Ella, Lawrence, Natalie, and if Rose is still around and wants to join, by all means, we can put Rose up on the screen too. If not, it'll be, yeah, Rose is still here, so that'd be great. So what I'll do is I'll go around each of you and I'll pose questions specifically. If you do want to chime in, as there is only 5 of us, please do. So just to start with, I know Natalie and Rose have already been able to introduce themselves. Obviously, they've already spoken on the event today. So Ella and Lawrence, I'll come to Ella first. Would you like to just introduce yourselves, give us your connection around type 1 and a little bit of background on what you're up to?
Sure. So hi, I'm Ella. I've had type 1 for, gosh, nearly 8 years now, and struggled myself with an eating disorder prior to being diagnosed. So I'm now fascinated in this area, really passionate about helping other people that have experienced similar things. And I'm actually doing a PhD looking at the communication experiences of people who have type 1 and disordered eating.
Lawrence?
Hi, I'm Lawrence. I am 31. I shouldn't have said that. I'm 21. I was diagnosed with diabetes when I was about 3 years old. And I wish I could say that I've been doing stuff like you guys for the community. I've focused entirely on myself. I've tried to become an actor and a singer, and I'm working in like film post-production and stuff. But it's only in the last couple of years that I think I've had the courage and the platform to talk. Yes, I'm just very thrilled to be here today. Thank you, everybody.
Great. No, thank you both for joining in. And I was just going to come to the first question. We've talked a lot around it today, and it would be for me just to say, what impact do you think living with type 1 specifically has had on your mental health? And I'll go with that question firstly. Sorry to pick on you first, Natalie, just because I'll give the other two a little bit of time to have a break over that one. So Natalie, you've obviously been able to give us some great insight today from a research perspective. Be interesting to hear your thoughts as a person living with type 1, as well as that background in research on that question. So what are your thoughts?
It's a really good question, and something that I've only really been thinking about kind of recently in my life. I mentioned in my first presentation that when I was diagnosed and growing up, number one, mental health wasn't mentioned kind of in general in healthcare and kind of the diabetes culture, I guess. And I just didn't think that it existed. I didn't think that diabetes had an impact on my mental health because no one was talking about it. So if I wasn't hearing anything about it, why would it have an impact? And so it was speaking to other people that kind of showed me, oh, actually, I struggle with that. And yes, I struggle with that. And oh, I've had that experience too. And even in the eating disorders research, I haven't had anything that I think could be diagnosed as an eating disorder. But speaking to people's experiences, I've realized, oh, actually, I dress the way I do so that I have a place to put my insulin pump. And that impacts the way I dress and the way I view my body and all of these things in my life. And so as a researcher with type 1, it's been really interesting studying kind of other people's lived experiences. I'm only one person, but listening to other people and kind of connecting with that within myself, realizing, oh, I've had a lot of support and I've been really lucky to have a lot of support, but I'm still impacted in more ways than even I realize, and that's been really interesting.
Thanks for sharing that, Natalie. And Lawrence, what are your thoughts on the impact that it's had?
Yeah, I think the same, maybe partly because I was maybe diagnosed in the Highlands of Scotland in the early 90s. It wasn't a consideration. I think they'd barely, like, technology was in such an advanced stage, they hadn't really considered all the things. And I wonder if perhaps because my parents were so heavily involved with my diabetes care, maybe the doctors gave all the bad news to them, and they, sorry to also use the sugarcoat pun, but maybe they sugarcoated it for me as a child. So then when I then became an adolescent, and then the control of diabetes was handed over to myself, I felt I was kind of then just, I wasn't prepared for all the repercussions of your behaviors, and finding out that, you know, so my eating disorder really kicked off, I'd say, in my teenage years, but I'm still feeling the after effects of it in my 30s. And I think you're living so much in the immediacy. I think diabetes has the capability to root you so much in the present. I am currently hypo, or I am currently hyperglycemic, that you don't think about later on. And yeah, so I think it's hard, because then you kind of also like admonish your younger self as well. And it's so hard to place blame on yourself, because he was just a kid, he didn't really know. But I should also still hold that compassion for myself in my 30s as well, because there's still things I don't know, or there's still tough days. And so yeah, I think it's hard. I try to look at the good side of diabetes, if there can be such a thing. You know, it does give me a sense of responsibility and compassion, I think, for others, and a good excuse to not do things if I don't want to, like the washing up. I think hypo. But I think it has provided quite a few stumbling blocks as well. So yeah.
Yeah, no, I can certainly resonate with a few of those. And what are your thoughts as well, Ella, on the impact it's had on you?
Yeah, so I think obviously there's the very clear impacts that everyone's already spoke of, but I use an analogy quite a lot when I'm talking about my own mental health and diabetes, and that's one of a cup of capacity, basically, just to deal with stuff in life. And I think managing diabetes always fills that cup up halfway, a certain amount, and it then just leaves me with less capacity to deal with other things when something else is going on. So it often feels very much like, you know, some small minor inconvenience in life might happen, or a small thing that I would otherwise be able to deal with emotionally happens, and because I have to think about diabetes as well, I just don't have the capacity then to cope, and that tends to spiral my mental health. So it's had a pretty massive impact in that sense. But I do try to look at the positives for diabetes as well in my mental health. And I think it's given me a level of resilience that I didn't have before, and kind of a strength in managing things sometimes. Yes, it reduces capacity and certainly has a negative effect too, but I try to look at the positives in that as well.
Yeah, no, I think I feel a lot around challenges, and I can hear a lot of what you've both said there, and Natalie as well, around how it's impacted on me and how I feel capacity to be able to deal with things outside of diabetes as well, and the strain that it puts on you, but also framing it positively as well. Tried my best to do that, and just want to bring Rose in on this. And Rose, I don't know if you've got any thoughts there, listening to us talk about it, as well as then I wanted to reflect on maybe my next question as well, around Melissa talked a lot about data, technology in her presentation earlier, and what impact do you think technology is now having maybe on mental health with type 1? Because there's probably a bit of both in here around positives and some challenges, Rose, and I wondered if you could also reflect on that as well for us.
Yeah, absolutely. So it was really interesting listening to everybody, and I think one of the things that struck me is that there's no timeline for psychological distress, that there's sort of distress that maybe people expect, like when you're first diagnosed, people would understand people feeling very distressed by that, but we know that it doesn't run in this sort of simple, straightforward pattern. And I see over and over again people having these life events, whether it's a breakup, whether it's going off to uni, whether it's something in your life happening, just moving house. All of these things can just set everything off again. And that move that you were talking about, Lawrence, to managing your own diabetes or moving from pediatric up to adult services, all of these things can really destabilize a person and can trigger off that distress. So I think it's really important to emphasize that that this is something that anybody can experience, and we're often in quite a precarious position, and it just takes something destabilizing enough to put people into a place where they really start to struggle. So I think it's really important to try and have those strategies in place as much as you can. And it's remembering as well that for a person living with type 1 diabetes, it's such a demanding, relentless condition, that talking about the sort of capacity that people with diabetes, you need to be, although it's frustrating and annoying sometimes, looking after your own well-being and actively trying to do things to counteract this stress on a regular basis. Because in order to manage diabetes, you don't just need to be at 100% of what sort of normal muggles would expect. You're at this sort of superhuman 130% all of the time. And so I think it's really important to recognise that that does take a toll, and it does need looking after that headspace, that capacity. It's really interesting what you're saying, Chris, about technology, because it's worked in lots of different directions. I think for a huge amount of people, and there's really solid evidence on this, it's taken off a lot of the burden of diabetes. Things like being able to sleep through the night and not worrying about hypos, that's huge. For people with diabetes and for parents of kids with diabetes, that's a massive, massive improvement. And also taking some of the guesswork out of diabetes, again, really, really beneficial, and often making healthcare appointments feel a bit more meaningful and honest, because it's not just you sitting in the waiting room putting 777 in your book sometimes. So that can open up some more meaningful and useful conversations. But at the same time, it's opened up this whole can of worms that I don't think many people were expecting. So things like the perfectionism that started when people suddenly had access to these Libra graphs. And of course, you've got to remember that when you're looking at a Libra graph on your phone or on the reader, that screen's really compressed. It looks terrifyingly spiky. And I think when it first came out, lots of people were under this perception that you should be aiming for a perfectly flat line and that you should be aiming for 100% in range, when we know, actually, when you look at the data on this, that people without diabetes get 76% time in range. That really annoys me. If people without diabetes get 76%, why does it even go up to 100? Why do we put that pressure on people? So I think that's definitely something that has had an impact. And of course, there's this thing of your data and your information. For a lot of young people that I work with, they often have this fear that we as the diabetes team are just there looking constantly, or your parents are there looking at your Dexcom, and you might be sort of out with your friends and suddenly you get this text message from your mum saying, what are you doing to your bloods? Are you going to take a correction? So it's unleashed a whole new host of stresses and difficulties. And I think sometimes as well, the expectations that we might have about technology, particularly when we're looking at things like the hybrid closed loop systems, that some of the messages around that it's this artificial pancreas, that it'll do your diabetes for you, when you actually get it, and the reality that you still need to carb count, you still need to be on top of all of your set changes. This doesn't do all of your diabetes for you. You might still have hypos. Sometimes the algorithm does go a bit wobbly. That disappointment can be really difficult, not to mention the fight, the battle that a lot of people feel like they have to go through with the diabetes teams in order to get access to this technology. That can have a real impact on your relationship with your team. If you feel like you've had to spend a lot of time campaigning and arguing and fighting for this stuff, having that ongoing relationship with your team further down the line can feel quite tricky. So I think there's lots of elements of technology and bringing in technology that has caused new stresses, not enough to outweigh the benefits of technology. We certainly don't want to give it back, but there are new stresses attached to that, and there's a lot that we don't understand. And I think there's a lot that we've still got to learn, because of course technology now changes how people manage their diabetes, and that in turn will change the psychological stresses that people experience. So for example, the work that Natalie and her team have been doing on the STEADY project, we don't know how eating disorders are going to look when most people are on hybrid closed loops. We don't know how that's going to change in the future. So this is very much a moving, changing condition, and healthcare professionals are desperately trying to play catch up with it.
Thank you so much for those reflections there, Rose. And I can see a few comments there, certainly around the time in range of people not living with diabetes is kind of, and that pressure of data and the slight ease, if you like, that people without the condition actually don't spend 100% of time in range. So I think it certainly made me feel better when I knew that stat as well. But I just wanted to see if there was anything to reflect on from Ella or Lawrence's, your perspective, but also now I wanted to also specifically pose to both of you. I know you've got experiences of Tide in your background, and I know you've done a lot of work with JDRF to support us in the support we now offer. So I wondered if you could maybe reflect on the technology side of things, and also talk to us a little bit about the background that you've had with Tide and maybe the factors that have influenced that occurrence for you.
Sure.
Ella, do you want to go first?
I'm happy to go. Yeah, I'm happy to go first. That's all right. So I think for me, it's the technology facilitates more data, right? And it's the data that I have struggled with at points. And it relates back to that perfectionism thing that was part of my eating disorder. So for me, my eating disorder was quite classical bulimia, which, and for me, the mindset was very much, I'll try and be as perfect as I can with what I eat all the time. And then as soon as I wouldn't be perfect, that would then trigger binges and overboard and shame spirals and all sorts of that sort of thing. And in large part, for me, a lot of that was not helped by being in a sporting environment where there was not a massive pressure to lose weight, but there was certainly a focus on what I ate, and weight cuts were part of the sport that I did. So I was very used to tracking food and macros and had been for years and years and years. And it was not so much, oh, I've eaten X number of things during the day, that's bad, that would trigger me. It was more looking at the macros and seeing the numbers. So I've always had a bit of a, I guess, yeah, a bit of a reaction where numbers are concerned. And it was seeing those numbers in the app that I used to track my macros that would kind of set me off. So then to become diabetic and start to look more at numbers and track things, that was a massive issue for me from the very beginning. I struggled very much to track the food that I ate and to track that against blood sugar readings. And again, because it's data and it's numbers, that kind of perfectionism and obsession around blood sugar levels, yeah, that was certainly a problem for me early on, and it's still something that I struggle with sometimes. My mental health is worse than at other points. And the only thing that I've really been able to do, and don't get me wrong, I love the technology. I think it's so helpful. I wouldn't live without my Libra, not a chance. But the only thing that I can kind of do for myself to help manage those tendencies is just try not to get too obsessive and try not to look too closely at the numbers. So I can kind of keep a vague track on what's going on data-wise. But if I start to look too deeply, focus too much, that's kind of where problems begin for me in terms of the mental health. So I kind of, for me, it's a soft touch approach with how much I focus on the data and how much I look at the data, because I'm very aware of my own reaction to it.
Thank you for sharing that, Ella. And Lawrence, do you want to give us a little insight around your experiences as well?
Yeah, sure. I mean, so I've only started using the sensor in the past couple of years, and I don't know if that was just a holdover from what I was used to. I was used to basically doing insulin by candlelight, and so the idea of integrating technology just seemed that's a bit weird. And I think it's a funny thing. It's also, diabetes is a constant thing. There's no escape from that. But I think going back to something that Jane, one of someone who's written in, asking about how to help with her son, like I've tried, and I don't know how successful I'm doing it, but I'm trying to move away from, it's a semantic thing, but not classifying myself as a diabetic, but rather a person with diabetes. And I think it is a semantic thing, but quite powerful. I think it is part of my life. It is not my entire life. And I think on your down days, it feels like it is the most overwhelming thing, and perhaps it will be. I kind of refuse to let it define myself, because as someone who used to have anorexia as well, I would call myself anorexic. But then, so when I started to enter my recovery stage, it was really hard to separate that identity of that I built up for myself as, well, if I'm not anorexic anymore, then what am I? So I think trying to, as the patient, try to start to pick apart even the way I referred and therefore thought of myself, because then I defined myself as such. And yeah, we're all more than the things that make up our little composite parts. Diabetes is obviously a huge part of my life, but I try not to let it be the part of my life. So if that helps, Jane, I don't know. I don't know. It's just this is probably slightly off topic, but when my eating disorder presented itself, I didn't even really consider my diabetes. My diabetes. I didn't think of my diabetes as being a contributing factor. I think just because it just became so every day for me, as I've said, having diabetes since 3 years old, it didn't really log for me that this could be a contributing factor. And even my healthcare team, they didn't pick up on it immediately either. And I think so that's why things like this are just so incredibly heartwarming for me, because being at the talk with that Theresa May and George Harris were holding, I remember someone mentioned having a hypo, and it was so it took me by surprise that I didn't need to explain to everyone else what hypo was. Everyone in the room understood what that meant. Because I think so often when I've been doing things with eating disorder talks, or even when I've been engaging in therapy, I personally haven't addressed my diabetes because I know that my therapist doesn't understand it, or other people in the room are like, sorry, wait, so you do eat things? Well, having to explain upon an explanation, it takes time. So I think it's just so amazing to be in a community here where everyone kind of gets the lingo, and it means that you can kind of get to the heart of the matter much quicker. Not sure if I just got to my point quicker there. I think I rambled.
No, that was great, Lawrence. And thank you for the reflections. I mean, it's given me a lot to think over as somebody living with type 1 too. And I'm just looking at the time, and in the interest of time and where we're up to in terms of the event, I'm hoping you'll all be able to stick around maybe for a few minutes to answer some of the questions that have been posed in the chat or the Q&A, because I think there'll be a fair few in there, which I'm sure people would be really grateful if you could give them a reply or an answer. So if you can, that'd be amazing. I did want to just ask one very quick question to all of you just to finish on. And obviously within your own experiences, what would be your kind of top tip for maybe keeping on track of your mental health whilst living with type 1? And I'll just go round to each person. I'll start with Ella. What would you say?
Honestly, for me, and I know this won't work for everyone, but for me, it's just not fixating on the negatives too much. I personally tend to ignore the negatives for the most part and just get on with life and try. I mean, like I said, don't get me wrong, the negatives happen, but I think for me, it's just focusing on the here and now and trying my best to live my life the way I want to, and not have diabetes dictate that for me.
Brilliant. Natalie?
I think on a similar note, my advice would be to just try and be kind to yourself. I think there was a question from Jane that was saying, there's conflicting things online saying that diabetes doesn't have to stop you and you can live your best life and all of this stuff, but also people are saying it's really hard, and it is, and just try and be kind and say, if I have a hypo and diabetes does stop me, or if my sugar is high and I feel like garbage and diabetes does stop me, or if there's something that I don't want to do because it's hard, then that's okay, and you're already dealing with a lot no matter what you're doing in your life, because you have diabetes on top of all of these other demands. So just try and be kind to yourself, and you know, yeah, just don't beat yourself up over some bad days, or not living your best life, whatever that looks like on the media and things especially.
Thanks, Natalie. Lawrence?
So annoying, because that was going to be my point. But yeah, self-compassion. I think I was saying to a friend yesterday who's going through a bit of a tough time, completely unrelated to diabetes. If you have a cut on your foot, you can see the cut on your foot, and you wouldn't keep walking on it and going, why is my foot still sore? Because you can see the cut on your foot. And I think people who are going through issues with their diabetes or with their mental health, the cut or the injury might be internal and you can't see it, but that doesn't mean it's not real and doesn't mean it's not there. And you wouldn't keep walking on a broken foot, or you'd rest it a wee bit, or you'd be compassionate to yourself, think, I can't quite climb that flight of stairs. So just having that self-compassion and self-regulate, and just being kind to yourself.
Brilliant. And Rose, so many tips I'm sure you could give, but what would you give us as your lasting final message from the event today?
Well, I think the most important thing I would advise anybody to do, whether they're an adult with type 1, a child, or a parent or carer, is find your tribe, find groups of people that can support you and share experiences with you. Events like this are so important, feeling that you're not alone in this, understanding that other people have the same struggles as you. So get involved with events like this, go to peer support. Things like the type 1 weekenders that happen are so important, and just feeling like you're not alone in this is so key.
Brilliant. Well, thank you all so much for giving up your time today to be involved, presenting, and in that panel with me there as well. Amazing reflections. Thank you for being so open and willing to share personal journeys, and I hope it's had a great impact for those that have been listening and watching. It now leans on me to just finish us off for the day now. So I'm just going to share my slides. Hopefully these will pop up. Can you all see the slides? I hope so.
Yes, Chris.
Brilliant. So I'm just going to spend a few minutes. I realise that we're already past 1 o'clock, or very close to. So I'm just going to spend a few minutes just sort of summarising and pointing in the direction of some of the things we've got going on at JDRF, which may be helpful, as well as things that you may wish to get involved in as well. So the first thing, obviously we've spent a lot of time today talking over mental health and supporting each other and emotional well-being. We do have our own page for emotional well-being, so if you would like to look over that and see some of the signposting information which lives there, as well as ways that we can potentially provide future support, please do head over to that page there, and the link is on screen. We've also had a discussion today around TIDE and disordered eating specifically. We again do have our own JDRF website page where a number of different signposting links are, resources are. Also, Lawrence and Ella's story is on there in more depth, so you'll be able to watch their stories on video via that page. And again, hopefully this can provide some support and a place to turn to should you need to. We've also talked a lot around reaching out to others and finding your tribe. I think was one of Rose's key lines there as she finished off on the panel. And peer support has gone up a notch in the last year or so, with principles now being delivered from NHS England and a real push now to encourage people and healthcare professionals to support the encouragement of people reaching out to each other and speaking about their lived experience. So peer support comes in lots of different forms and in lots of different ways. So I've just put a few different places up here. This is not an exhaustive list of peer support communities. It's just a few places you can find them and reach out to. But again, if you want to find out more or a place for other groups, you can reach out to JDRF as well. and I'll come up and I'll show the place to do that in a couple of slides time. But peer support can really help with addressing the challenges that we've talked about today. So yeah, find your tribe, and maybe one of these communities which is on screen now might be the place for you. We've also got a number of different resources that just provide general support in different areas across JDRF. So whether that's our university toolkit, whether that's a pregnancy toolkit, whether that's a kids SAC and supporting children and parents, you can find that on the link there on screen, as well as then by scanning that QR code to find further support from us, both in hard copies as well as electronic ones too. There's a number of different ways to get involved at JDRF in terms of volunteering. So there's our Insight and Experience panel. You can volunteer at one of our events. There's a Youth Ambassador program as well, which is launching and growing all of the time. And also we have our active events and fundraising opportunities too, to help JDRF continue to push for more support for people with type 1, as well as driving towards that cure and improvements in treatments and technologies for people with the condition as well. You can find out more on the link. And our next community event is going to be in Glasgow on the 22nd of April. So we'll be heading to Glasgow to run our Discovery Day there, where we'll be doing a speaker agenda as well as a technology exhibition, where you'll find our partners and our corporate sponsors that have been involved today. They'll be there to help support the community as well. So that'll be on the 22nd of April. We then will also head to Northern Ireland in May, on the 13th of May, to Derry. So if there's anyone from the Northern Ireland community as well, do note that date down, and hopefully they will be soon on the website up so you are able to register. We've also got some really important community / fundraising events, with the One Walks coming up in June. So hopefully you'll be able to see the dates coming up. They're an amazing opportunity to come together as a community, speak to others, as well as importantly raise funds for JDRF to continue the work that we're doing for our community. So there's some dates there on screen for London, Glasgow, Cardiff and Manchester, and you can register on that link there, jdrf.org.uk/onewalk. We've also got Cycle for a Cure, which hopefully you've seen the slides in our comfort break showcasing as well. So that'll be coming up at the end of April. So if there's any keen cyclists out there, or leisure cyclists as well, and there's different ways to take part. There's more serious, longer duration, and there's also the shorter sort of durations where you might want to take part as a family as well. Cycle for a Cure, we hope we can cover everybody within that. So if you want to get on the bike and help us towards our objectives as a charity, please do reach out and get involved. And you can do that by reaching out to our events team on that email on screen there. So if anyone wants to take part in anything fundraising specific for JDRF, please do reach out to the team there. That's all from me, and I wanted to hand back now to Hilary to say our final thank yous and say a big round of applause for everyone that's been involved today. So back over to you, Hilary.
So I hope that that's been a really useful event for everybody here. I'd like to thank our partners, our corporate partners, and to Toshiba Tech UK. And please do reach out to us. Please email us. Please contact us. And know that there's lots of events that we're doing, both virtually and in person. We are here for everyone. We are the Type 1 Diabetes Charity here in the UK. And any questions, please do reach out. So many thank yous, and thank you to all our speakers and participants. Thank you.